Welcome, everyone, to the Maternal and Infant Health Equity Summit. I'm Dr. Judy Salerno, President of the New York Academy of Medicine. Today's summit is sponsored by NIAM in partnership with the Icahn School of Medicine at Mount Sinai in New York City and the University of Pennsylvania Perelman School of Medicine, Department of Obstetrics and Gynecology. We're here today at this important convening because we're all aware of and deeply concerned about the unacceptable and long-standing inequities in maternal birth outcomes that have persisted over decades for women of color. The Academy, now in its 174th year, has always been committed to tackling the barriers that prevent people from living a healthy life, whether rooted in access to health care or structural issues, especially racism. One of our earliest publications in 1928 identified racial disparities in birth outcomes. Nearly 100 years later, we have not made significant progress in reversing those trends. NIAM remains fully committed to our mission of advancing health equity, and there'll be no better indication of our progress or lack thereof in achieving health equity than looking at maternal birth outcomes. I hope that the summit will continue to galvanize our efforts to find actionable steps to tackle those seemingly intractable problems through a scientific and equity lens. Thank you for joining us today. Danielle?
Good morning. My name is Daniela Roccarina. I'm a pediatrician, and thank you, Dr. Judy Salerno, for your words of encouragement. My talk today and my task today is to organize us around a framework for action. I have nothing to disclose, and I said, for those of you who heard, except for my passion for maternal and child health. I do want to take a moment, however, to reflect on the context of our summit. We are in the midst of a COVID-19 pandemic, something that I think I can say assuredly that none of us have experienced in our lifetime, and a national call for racial justice. The combination of these two are really staggering. And so I want you to take a moment. I want you to take a moment and close your eyes and reflect on the losses in 2020, but then re-engage to really commit to making a change in 2021. So please take a moment. Thank you. So we begin with something that most of you are very familiar with, okay? You heard Dr. Salerno mention that what we are asking you to do, which is a monumental task, is to begin to focus in a sustained way on health inequalities as well as health inequities. And so a bit of definition. So health inequalities really refers to the outcomes. She mentioned the disproportionate deaths to birthing people of maternal related to pregnancy related deaths. And that these outcomes in both those who are giving birth and to their infants and children is an outcome. It's a disparity and a gap in health status. What we will ask you to do today, however, is to put an additional lens on of health inequities, which really speaks to the causes of those health disparities in disadvantaged populations. To have that social justice lens that requires a more in-depth engagement with communities, and understanding that while we live this moment in time, we hope to have a lifetime of health. And so a life course perspective, beginning preconception through pregnancy, through childhood and adulthood and geriatric age, is that lifetime perspective is keenly important. And therefore we have to tackle the structural determinants that produce social and health inequalities. So this lens, and I hope you are imagining this, because we will ask of you the task of really engaging fully. So what is health equity? We mentioned very briefly. Who is it for, right? We're going to ask you that. You've already heard that we're focusing on Black, Brown, and Indigenous women, and we will present research data to you that will convince you that not only do we know how to define the problem, but we actually have solutions to those problems. And we will recruit your input as to what those solutions might be. We're going to ask and discuss, why is this important? You know, women and children, unfortunately, have often been marginalized, although obviously women represent more than 50% of the population. And if I don't have to remind us that we were all children, right? And that we must invest, not in monetary ways only, in the success of our society to support children and then to grow up and to contribute to a healthy society. How do we get there? These are some of the things we will tackle with you. And how will we know that it makes a difference? We must use data and measurement. Many of you have seen the health equity frameworks, or different health equity frameworks. And this is just one that has been published. And I thought I would review very quickly for you this. We've talked about social determinants. Now, it's no surprise to those many who lived in so-called disadvantaged communities that social determinants of health are the key determinants of health. So what we do, and I'm a physician, many nurses, other health professionals, I'm sure in the audience, is to care for individuals, hopefully in prevention, but throughout the course of illness and recovery, but that we know that what we do is but a fraction of what determines overall health. So those social determinants, for example, poverty, housing, education, are critically important for us to focus on. And that means that I'm asking you to go out of your lane. Out of your lane means that while you want to focus deep in the areas that you are expert in, it is only through our collective efforts will we get to a reduction in maternal mortality. We need to look at life course issues, as I mentioned. The other thing that's critical and was emphasized in the Helsinki Health Across All Policies is that we must, as health professionals, interdisciplinary folks, actually imbued health in all the policies that we have, because we know that there's a larger framework. We know in the 21st century that social marketing, that is information, health information, is critically important. We're in the midst of a pandemic where we have seen the evolution of that information highway, and that we must be a part of that. We must be engaged in community-based participatory research that doesn't ask communities after the fact, but fully engages youth and community residents in defining the problems and in being part of the solution. And we must bridge this focus on clinical practice to actual health promotion through a translational pathway. So I was honored to be one of the 4 co-chairs when the governor put together the governor's task force on disparate racial outcomes. And I'm presenting you very briefly the leadership and the recommendations from 2019, and they are published and you can download them on the web. I want to recognize, obviously, Dr. Howard Zucker, who is the Commissioner of New York State Department of Health. And we are joined today by 3 of us who actually co-chaired this task force. Sasha James Contorelli, who's president of New York State Association of Licensed Midwives, myself as former president of the State University of New York, Medical University at Upstate, and Wendy Wilcox, who's the chair in the Department of OBGYN and New York City, Icahn County. There were 27 members of this task force, and 6 of us have joined here in addition to an effort at NIAM in developing the NIAM Women's Health Research and Wellbeing Work Group, and are participants in this current Equity Summit. So what I want you to focus on is some of the work that has been done in the past, as Dr. Salerno mentioned, and then engage fully in this current endeavor in the work that needs to occur to have sustainable change. The recommendations, without going into each of them individually, is to be guided by data, right? And to make those data publicly available so that we can be accountable to ourselves, first of all, because we know that all of you care deeply, but that data inform our interventions. We must be engaged in training and education that fundamentally changes the structure of what we're doing. We must take a look at quality of care and know that it doesn't matter if you deliver in Queens, in the Bronx, in Manhattan, in Staten Island, anywhere in New York, and anywhere nationally or globally, that the quality of care will be equal and at its highest level. We must look then deeply at the financing of care. Yeah, it all comes down to money. And we must set our priorities straight. We must be interdisciplinary, and we must have a global universal view. So that's a large task, but these are the things that were outlined in the recommendations from the task force. I will defer to to my colleague, which I'm blanking on, Dr. Elizabeth Powell, forgive me, Liz, it's early in the morning, who will describe to you the planning committee and all of its efforts. So the mission, I mentioned that NIAM, the New York Academy of Medicine, has had a deep commitment to women's health, and we have reinvigorated that in the mission statement that you see here to not only advance health, but healthcare and equity and eliminate structural inequities throughout the life course. And to tag that on to maternal child health, because we must never, through our policies, be divisive and separate the health of the woman from the health of her infant. Her health is critically important and is a determinant factor in the health of her infant. And so we founded, Dr. Howell and myself founded this new work group, which will evolve to a section of the New York Academy of Medicine. And you see the prominent members of that. And I thank the members of the work group. So in closing, what I'd like to ask you to do is the following. We will be talking about many issues this morning that are based on incredible data that Dr. Howell and her group will be presenting. And I'm asking this monumental task that you look at the whole picture. You've heard of the statement, you need to look both at the forest and the trees. The systemic change is the forest that then defines the infrastructure of support from the front lines to middle management, to higher management and leadership at all levels, including national levels. But I also am asking you to focus deeply in the areas of comfort that you have in your day work, but then go outside your lane to take a look at the areas of discomfort that will challenge our systems of care and challenge our systems of financing to make fundamental change. And while I say that we need to move beyond individual responsibility, I thought I would end with the following slide. You know, this has been a difficult year, 2020. And as I thought about it, yes, this is my daughter and my two grandbabies, Margot, who is 3, and little Harper, who was born during this incredible pandemic and the outcry for racial justice. These are all of our daughters, all of our sisters. And Morris Green, a pediatrician, said, good clinical medicine is always highly personal. So while I'm asking you to delve deep into systems changes, keep it close to home. Care about our daughters and our sisters. So thank you. And now I will transition and hand over the program to Dr. Elizabeth Powell. I want to point out that you have many bios that you can refer to, and therefore we will have brief introductions of each of the panelists and the moderators. But Dr. Howell is an incredible researcher, clinician, and woman. She's the chair of the Department of Obstetrics and Gynecology at the Penn School of Medicine and University of Pennsylvania. Previously, she was a professor of population health and policy in obstetrics and gynecology and reproductive science, and the founding director of the Blavatnik Family's Women's Health Research Institute at the Icahn School of Medicine at Mount Sinai. She's NIH funded, and I know she just received another R01, so her work is ahead of her. She is NIH funded in health services research and a major researcher. Again, I could go on, but I'm going to hand over the podium to a virtual podium to Dr. Howell, and I see her wonderful smile to really guide us through this. And you will see me intermittently throughout this. And again, please focus with us, engage with us, and I thank you for joining. Dr. Howell.
Thank you very much, Dr. Arena. And could you just allow me to share screen if you could stop sharing?
I did, thank you.
Great. And I just want to confirm that everyone can see my slides.
Yes.
Good morning, and thank you for joining us for the Maternal and Infant Health Equity Summit. A few years ago, Linda Villarosa published a piece entitled, "Why America's Black Mothers and Babies Are in a Life or Death Crisis." She went on to say that the answer to the disparity in death rates has everything to do with the lived experience of being a Black woman in America. Systemic racism has taken an extraordinary toll on the health and the wellness of Black women and babies. We are here today to develop actionable items to improve maternal and infant health equity. This is meant to be an inclusive summit, and the lessons learned from our discussions today have implications for Black, Brown, and Indigenous birthing people. We refer to women to describe pregnant patients. However, we recognize that people of various gender identities, including transgender, non-binary, and cisgender individuals give birth and receive maternity care. There's a long legacy of racism and discrimination that has been experienced by Black women in this country, and most of the research to date has been on cisgender women. We have much work to do to expand our definitions and collect meaningful data on all birthing people. So I think everyone in this audience is well aware that of the longstanding and persistent racial and ethnic disparities in pregnancy-related outcomes in this country. And here's data from the CDC showing us that Black women are more than 3 times as likely to die from a pregnancy-related cause. That's a death within 1 year. And American Indian or Native American women are more than twice as likely to die. These disparities are more acute in some of our cities, and in New York City, Black women are 8 times more likely to die. And again, this is data from the New York City Department of Health and Mental Hygiene. Intertwined with these maternal health disparities are the long-standing infant mortality disparities by race and ethnicity in this country. Again, with Black infants being more than twice as likely to die as compared to white infants in their first year of life. Again, we see that these disparities can be slightly different and more pronounced in various cities. And in New York City, it's about 2.5 times. So embedded within these disparities are the ongoing effects of institutional racism, dating back centuries, ingrained in our earliest institutions, and continuing to influence policies and practices today. I think it's helpful for us to consider the many ways in which policies and practices have impacted the lives of Black women and children and have helped to shape their health. Let's start with thinking about the 1935 Social Security Act, which included today's welfare benefits of unemployment and Social Security. It excluded individuals who worked on farms or as domestic help, which were primarily jobs held by Black Americans and people of color in the 1930s. Thus, from its inception, it created a system where government aid was reserved primarily for white people. Many of you are familiar with redlining. In the 1930s, the government began a practice of redlining neighborhoods based on how secure they were to invest in, and redlined neighborhoods with the highest risk. Not surprisingly, redlined areas were occupied by Black families. Those neighborhoods rarely qualified for federal housing assistance, and they became underdeveloped. And it created a cycle that deterred future investment. And even though the practice was eventually banned, we still see the effects today. In fact, a recent publication in AJPH by Krieger and with the senior author of our former Commissioner of Public Health in New York City, Dr. Mary Bassett, showed the association between historic redlining in New York City and the risk of preterm birth. I think we also, especially in this time of the COVID vaccine, are remembering all the numerous reasons that Black women may mistrust our healthcare system because of so many policies and practices that were used to devalue them. Think about James Marion Sims, who was called the father of gynecology, who performed multiple experimental surgeries without anesthesia on enslaved Black women. Let's think about the enforced eugenic programs that sterilized Black women. And healthcare segregation continued into the mid-1960s, with Black families barred from certain hospitals even after the Civil Rights Act. Hospitals serving primarily folks of color were under-resourced, and we continue to see this pattern today, and we'll be sharing some research on these findings. And finally, let's think about the tumultuous events of this last year. The disproportional impact of the COVID crisis on communities of color, the George Floyd killing and its aftermath, the divisive election, and most recently, the storming of our US Capitol. These crises have put a spotlight on systemic racism and how deeply entrenched it is in our society. All of these policies and practices, as well as many more, shape our healthcare system and underline many of the health inequities we see today. So where does quality of care fit in? The Institute of Medicine published a landmark report in 2002 entitled Unequal Treatment. It documented racial and ethnic disparities in care across a wide range of illnesses and services. It documented that people of color receive lower quality of care frequently, and that provider stereotype and bias contribute to these disparities. This research prompted the Institute of Medicine to add equity to a list of aims for the US healthcare system. However, efforts to address equity have been given less attention than improving quality and reducing costs. In addition, some of our quality improvement activities have actually widened disparities. In fact, equity was called the forgotten aim in a recent Institute for Healthcare Improvement white paper, which noted how little progress we really have made towards achieving health equity. So what about quality, disparities, and maternal and infant health? There's an abundance of research that has documented that we have significant racial and ethnic disparities in maternal and infant mortality. And we are here today because of this public health crisis. But death in both settings is just the tip of the iceberg. Severe complications for moms and babies are much higher for people of color. There's growing evidence that quality of care may be one of the underlying causes that contribute to these disparities. Research has shown us that quality of care varies across delivery hospitals and across neonatal intensive care units. And site of care or hospital is receiving increasing attention as a mechanism for disparities. So today we will be presenting our research, our NIH-funded research on the contribution of quality of care to racial and ethnic disparities in maternal and infant health outcomes. We received funding, RO funding for 2 studies from NIH. One was on moms and specifically on severe maternal morbidity, using both quantitative and qualitative methods to gain a better understanding about the ways in which quality of care may contribute to disparities. And the second one was on the infant, on the very preterm birth infant, those less than 32 weeks, and looking at morbidity and mortality across hospitals. And the final phase for both studies is a dissemination of our findings to a national audience. And that is what began this journey of putting together this Health Equity Summit. The objectives of our summit are to first disseminate research findings on quality of care and disparities to a national audience, to engage stakeholders, researchers, community organizations in interpreting these findings and adding their own perspective and sharing their best practices from their own organizations and places of work and experiences, to share best practices of high-performing hospitals, and then to develop priority actionable items to improve equity. We decided to expand this summit to include many voices around the country and beyond who work on maternal and infant health equity and quality. And I'd like to take a moment and really thank our planning committee who helped to shape this day. We've in fact, as a group, been working on this summit for over a year. We had started this journey prior to COVID pandemic and had planned for a large gathering at the New York Academy of Medicine. And obviously, because of all the things that have been happening, we had to delay that. But I am so grateful to all of these people for their help in thinking about how we might be most effective in sharing our messages and who we might help invite to this summit who can share really important lessons with this audience. Again, I want to acknowledge NIH for the funding of not only our research and this dissemination phase, that's both NICHD and NIMHD. And then I'm going to take just one moment to go over a couple of housekeeping items for today. First, I want to begin by thanking all of the presenters, the speakers on the panels, as well as the individual presenters. We want to be respectful of everyone's time, so please understand if Dr. Larakarina or I give you a gentle nudge to come to a close. We're so excited to learn from you, but we also want to learn from everyone. To the audience, please put your questions in the question and answer box. We will try to incorporate those during the panel discussions today. And again, as Dr. Larakarina said, please refer to your bios for a more detailed introduction. We'll be trying to keep our introductions brief today in an effort to move our discussion along. So now I'm going to talk to you about the current maternal health care crisis. So I already mentioned these longstanding and persistent disparities in pregnancy-related deaths, and here's data just on New York City specifically from our New York City Department of Health and Mental Hygiene. And again, you can see that Black women are 8 times more likely to die from a pregnancy-related cause. But you can also see in New York City that Latinx women, as well as Asian Pacific Islanders, have elevated rates of death within the first year of life. But as we talked about, death is really just the beginning. It's the tip of the iceberg. For every death, over 100 women experience what we call severe maternal morbidity, which is a life-threatening diagnosis or undergoing a life-saving procedure. Something like a seizure, a stroke, bleeding so much from your delivery that you actually end up having a hysterectomy. This occurs in over 50,000 women in the United States every year. And here are the rates of severe maternal morbidity in New York City by race and ethnicity. And you can see that Black women are about 3 times, and Latinx women are about twice as likely to die from twice as likely to experience one of these events during their delivery. So how did we get here? I'm a health services researcher, and we can think about, I already taught to you about how we have to really recognize the role of structural racism and discrimination in our country and how it shapes policies and practices. We can then think about patient, community, clinician, and system factors. We can start with age and education, employment and language. Think about knowledge, beliefs, and health behaviors. Community factors, such as social network, neighborhood, poverty, built environment. Clinician factors, such as knowledge and experience, communication skills, bias, and then system factors, access to high quality care, transportation. These all combine to form and shape a woman's health status when she becomes pregnant. She may or may not have hypertension or diabetes, things that put her at risk for having a severe maternal morbidity or mortality. And then she interacts with the healthcare system, preconception, antenatal, delivery, and postpartum. And one of the themes you're going to hear about today is to really think about this whole continuum of care and life course. But the research that we did primarily focused on delivery and hospital care. So again, our study included 4 phases: a quantitative phase that examined hospital risk-adjusted severe maternal morbidity and racial and ethnic distribution of deliveries. The second phase was a qualitative phase with qualitative interviews to examine safety culture, quality improvement, and other factors that may explain the wide variation in hospital performance. Focus groups to explore patient barriers to receipt of high quality care. And then again, in this last phase, which we are in now, dissemination efforts to increase uptake of best practices. So our first phase included birth certificate data or vital stats linked with discharge abstract data for New York City Sparks. We used the CDC algorithm to identify severe maternal morbidity. We used mixed effects logistic regression to calculate risk standardized severe maternal morbidity rates for each hospital. We ranked hospitals based on this metric. And then we assessed Black-white differences and Latino-white differences in delivery location. We did risk adjustment and included sociodemographic characteristics, clinical and obstetric factors, and maternal comorbidities when we were ranking the hospitals and looking at their performance. So here are the hospital rankings for the 40 hospitals that were included for severe maternal morbidity. And the takeaway from this slide is really the wide variation. There's about a 6 to 7-fold variation in risk-adjusted rates of severe maternal morbidity in New York City hospitals. We then divided the hospitals in tertiles based on their performance. And we had the low morbidity cluster, medium morbidity cluster, and high morbidity cluster. We then looked at the distribution of deliveries by race and ethnicity and those clusters. So you can see on this slide, for all the Black women who delivered during this time period, 23% in light blue delivered in the low cluster, the hospitals that had the low morbidity rates, that third. You can see at the same time, 65% of white women delivered in those hospitals that had low risk-adjusted rates of severe maternal morbidity, while 33% of Latino mothers. As opposed to when you look at who delivered in the high risk-adjusted severe maternal morbidity hospitals, 37% of Black women, 18% of white women, and 29% of Latinx women. We next did a thought experiment and asked, well, what would happen if we changed and we just changed the hospital of delivery for folks? So we kept everything about a mother the same. She's Black, she has a specific BMI, she has hypertension, whatever her characteristics were. The only thing we changed was her hospital of delivery. So if 10% of white women went to hospital A, which was the lowest hospital with the lowest severe maternal morbidity rates, then 10% of Black women did. And then if 5% of white women went to the hospital B, which is the second lowest morbidity hospital, then 5% of Black women did that. And we did that across the whole distribution so that the distribution of deliveries for Black women mirrored the distribution of deliveries for white women. And we found that up to 48% of the Black-white disparity and 37% of the Latinx white disparity was attributable to hospital of delivery. So next, for a qualitative phase, which was our second phase, was really hospital qualitative interviews, looking at hospital factors, quality, and disparities. And so we started thinking about what were the levels of things that we wanted to ask about. We thought about structural characteristics of a hospital, like the volume of deliveries, the qualifications and equipment capacity for different labor and delivery units. We thought about organizational factors, such as culture, leadership, communication, feedback, and audit. We thought about clinical processes, the use of evidence-based practices, again, the quality of care and patient safety, as well as the actual outcomes that our hospitals had. We layered that with a conversation on disparities and bias, diversity, communication, and families. So again, we had ranked the hospitals based on risk standardized rates into 3 groups: low, medium, and high severe maternal morbidity rates, risk adjusted. We selected 4 hospitals from the high morbidity group and 4 hospitals from the low morbidity group from both hospitals. The other criteria that we used in the selection of those hospitals was thinking about volume of deliveries, percent Black, percent Latina, percent Medicaid. We wanted to have hospitals, for example, that had a high percent Medicaid that were in the low morbidity cluster of hospitals and also in the high morbidity cluster of hospitals. So we could learn and see if there were some lessons that we could gather from seeing what was going on in those different types of hospitals. At those hospitals that had similar Medicaid percentage, but had different performance. We ended up including 8 New York City hospitals. We did 50 interviews. These interviews occurred primarily in 2018. All the respondents were consented, interviews were audio taped and transcribed, and we worked with a qualitative research team and they were blinded to hospital ranking. Here is a list of the types of folks who we interviewed. You can see that we talked to chairs, we talked to physician directors of L&D, we talked to physician, nurse quality and safety lead, nurse managers, frontline nurses, chief medical officer, and then in some institutions, we talked to a couple of other folks in different kinds of roles. So how did we approach the analysis? We divided the hospitals into two clusters, as you heard. We analyzed the themes by cluster without a priori knowledge about performance. So again, this was the qualitative research team that did that work. Determined the overall themes, distinguishing themes, major versus minor themes. And then the final step was for the research team to interpret these findings with the knowledge of performance. So what did we find? These were themes that were shared both in high and low performing hospitals. Everyone was committed and believed that they provided equally good care to all patients. Everyone was very focused on and spoke about the importance of communication, not only between providers and patients, but also between physicians and nurses, and that this was a critical factor in quality. They varied very much in what they had done and actions they had taken to improve quality. When we asked questions about maternal morbidity and mortality, respondents really just pointed to things outside of the hospital, talking about neighborhoods and so primarily social determinants of health, but didn't really focus in on what was happening within hospitals and quality. Nurse staffing issues were a big issue across many hospitals, shortages, variation in experience of the nurses. There was wide variation in quality measurement and improvement, not only on the metrics used, but on personnel who were devoted to those activities. Individual adverse events were more likely to lead to quality improvement than monitoring trends. And no one at that time analyzed data to compare performance across race, ethnicity, and insurance source. What about the themes that we found that distinguished high versus low performing hospitals? Our data suggests that high performing hospitals had a stronger focus on standards and standardized care. There was a stronger focus on nurse physician communication and teamwork, more things that were done around interdisciplinary focuses. There were less communication gaps between nurses and physicians. Sharing of performance data with nurse and other frontline clinicians was more evident in the high performing hospitals, and that sharing of performance was quite a noticeable a difference. Senior leadership was more involved in day-to-day quality activities, and there was more focused on supervision. And finally, there was more awareness that disparities and racism may be present in the hospital and could lead to differential treatments. So next, we conducted phase 3, which was focus groups. We conducted 3 focus groups and we stratified them by race and ethnicity. So we had a self-identified Black group, a self-identified Latina group, and then we had a self-identified white and Asian group. All the mothers who participated in our focus groups had experienced a severe maternal morbidity, such as a hemorrhage, an intensive care unit stay, a hysterectomy. And we explored with these women how they experienced care. So the first theme that came out were that women were very traumatized, and it was an incredibly scary event. Many never wanted to have a child again. And again, I think we're learning more and more about the post-traumatic stress of these severe events and what it means for women. This was complemented with gratitude, because many of the women thought and feared for their life. There was poor communication. Quote, they just rushed me to the OR and I was just lying there. I'm cold, I'm shaking. I know I'm not feeling good, but nobody's telling me anything. Not feeling heard. I essentially diagnosed my own pulmonary embolism because nobody was listening to me. It's very scary to me how much I really had to advocate for myself. And the Black and Latina mothers spoke about subtle discrimination. Their access was limited by their insurance because the Black and Latino mothers in our focus groups were primarily insured by Medicaid. They also noted less time being spent on education and preparation for during their antenatal care. So the research that I've shown you and spoken to you about was really documenting and thinking about between hospital differences, how there's such a wide variation in performance, and how Black and Latino mothers deliver at hospitals that have higher risk-adjusted morbidity rates. But our team also did explore within hospital disparities. We wondered whether within hospital racial disparities in severe maternal morbidity existed, and if they existed, were they explained by Medicaid insurance? Again, because in New York City, Black and brown women are disproportionately insured by Medicaid. We use logistic regression to reduce risk-adjusted rates of severe maternal morbidity for patients with Medicaid and commercial insurance, and for Black, Latina, and white patients within each hospital. We then compared these within hospital adjusted rates using paired t-tests. And we found that women insured by Medicaid, compared with those insured by commercial insurance, had similar risk for severe maternal morbidity within the same hospital. So in other words, commercially insured and Medicaid women had the same risk for severe maternal morbidity within any given hospital. But in contrast, Black women, compared with white women, had significantly higher risk for severe maternal morbidity within the same hospital. And you can see Black women in this slide in green and white and blue. So within each hospital, these are risk-adjusted rates, again, accounting for things like obesity and health insurance and all these other factors, had higher risk-adjusted rates. We also found similar findings for Latina versus white women. So again, both between hospital disparities exist, as well as within hospital disparities exist by race and ethnicity in New York City hospitals. So where do we go from here? Again, we need to be focused on our life course perspective. We need to promote contraception and optimize preconception health, especially women with chronic hypertension, women with diabetes, optimize their health before they get pregnant. We need to think about new models of care, centering, which is group prenatal care, medical homes, enhanced models for high-risk women. We've been doing a lot of work on quality improvement on labor and delivery, standardization and bundles, team trainings, protocols, very important. There's been a lot of effort over the last year, I think around the country, certainly at Penn, at Sinai, and I'm sure many others around disparities dashboards, stratifying quality metrics by race and ethnicity, and looking at performance and developing quality improvement to target the gaps. New models, because postpartum period is so critical to a woman's health, not only for her next pregnancy, but also for future life. And we know so many of these deaths, about 50% are happening after delivery. So we need to really focus on that. There are new models around patient navigators and case management. I think we all are so well aware of what happened to Serena Williams. We know about the sort of moving work, and I always like to mention them because I really feel like ProPublica and NPR launched this awareness campaign around maternal mortality in this country a few years ago. And in one of their earlier articles, they talked a lot about how they collected stories from Black women, and over again, Black women reported the feeling of being devalued, disrespected by medical providers. That this is something that we have to grapple with within our healthcare system. And so therefore, we really need to do these programs around bias trainings. I think we need to think about the most effective ways, and we need to do more research about how implicit bias training might actually impact outcomes. But I think we need to think about explicit bias as well. We need to enhance our communication, not only between patients and physicians and nurses, but also on our teams. And we really need to engage community. We need to engage community in quality. So this was part of something that I did with, I worked on with a team around the country to develop a bundle around how might hospitals and healthcare systems think about reducing peripartum racial and ethnic disparities. And some of the key points were: make sure you're collecting self-identified race and ethnicity, implement disparities dashboards and utilize quality improvement tools to address the identified gaps in care, provide education on cultural humility, shared decision-making, implicit bias training, Provide education on racial and ethnic disparities in maternal outcomes to your staff and your providers so that they're educated and understand what's going on. Include community members in quality committees. Utilize enhanced severe maternal morbidity and mortality reviews within your hospitals. Think about the social determinants, think about structural racism, think about the role of all these things, and promote a culture of equity similar to what we see for a culture of safety. I also wanted to quickly just let you know about work the CDC has been doing. Another working group that I was a part of and led was really responding to maternal review committees across the country, reporting that the role of bias in maternal death was not a distinct category for the maternal mortality review information application system, which is really just a database that provides standardized forms for these maternal review committees to sort of input data. So our work group aimed to design a consistent approach for documenting racism and discrimination as contributing factors to pregnancy-related deaths, and to provide recommendations on how to prevent pregnancy-related death when bias is a contributing factor. And so I won't go into the exact definitions, but we came up with definitions for discrimination, interpersonal racism, and structural racism that have now been added to this contributing factor key for the CDC. I'd like to just conclude by thanking my research team. Been working with these folks, many of them for over 10 years, the majority of them for over 10 years, and they're all very committed and have, it's just an interdisciplinary team, and I think we challenge each other, and that's the group that's really responsible for the research that I presented today. I'd like to thank our funder, NIMHD, and I'd like to thank you in the audience very much for listening today. So next, I am very pleased, we're going to continue the program, and I'm very pleased to introduce Dr. Karen Scott. She's an associate professor and an OBGYN hospitalist in the Department of Obstetrics and Gynecology at the University of California at San Francisco. Her research examines interventions to eliminate and reduce inequities in sexual, reproductive, and perinatal health services provision through the integration of Black feminist and reproductive justice frameworks. I think we're all very excited to hear her today. Welcome, Dr. Scott.
Thank you, Dr. Howell, and everyone else. Let me get my slides situated. Thank you for being able to share information about my study today. Okay, so good morning, everyone. I will be discussing ways in which to advance cultural rigor in maternal and perinatal quality improvement, particularly focusing on Black women's birthing narratives and the first and only soon-to-be validated patient-reported experience measure of obstetric racism. And as you heard in the introduction by Dr. Howell, other things I just wanted to share with you in terms of my positionality so that you can really begin to understand why this work is so important to me, but why it's also a form of activism for me. I am Southern born and raised from East Nashville before gentrification. My education has been in the liberal arts since the 5th grade, middle school, high school, college, and also the medical school that I went to. I am a lifelong learner. I do believe this is the way. I also identify as a reproductive justice avenger, Wakanda healer, Yoda follower, and a Care Bear hugger. So this time is particularly hard right now with our social distancing, but we will push through this and get through this. And my main purpose really is to advance Black feminism, reproductive justice, and research justice through the operationalization of cultural rigor in participatory quality improvement science, practice, research, as well as policy and interprofessional education and training. So I like to always start like, where do I hope that we can end up? And for my group and I, sacred birth for Black mothers and birthing people particularly is very important. It is a radical attitude that is towards human birth, specifically Blackness, Black bodies, Black womanhood, that regards all the birth activities as fundamentally normal, healthy, spiritual, transformative, erotic, communal, emancipatory, and power activating. We also believe the sacred birth encourages diverse and inclusive birth pleasure, practice, care spaces, options, partners, and communities and experiences. And we do believe the sacred birth movement does advocate for safer, respectful, more dignified, high quality, participatory birth care conditions, experiences, outcomes, and an improved workforce, diversification, development, sustainability, and really a restoration of Black midwifery as part of the campaign. Our truths. So it's just very important to be transparent around our truths and what we believe and how that is guiding our ethics, our theories, our methods, and our dissemination approaches. We do believe, trust, value, and adore Black people, women, and mothers. We do believe Black women, people, and mothers are worthy. We protect, prioritize, cite, and amplify Black women's people's voices, intellectual thoughts, lived experiences, and political activism. We do believe that we activate, not empower, but we activate and advance an innate power and potential and not pathology of Black people, women, and mothers, and our given and chosen kin. So when we begin to think about what are those contributing factors and actors in maintaining this persistent death gap between Black mothers and people and other racial and ethnic groups. In other presentations where I speak for a longer time, I do focus on things around in this kind of circle here. They're all connecting, really again, focusing on what are our ethics? What are the guiding moral principles that are guiding the ways in which we do conduct our research? What is guiding our methods? What is guiding the way we spread or share information, and how our leadership and ethics really go hand in hand? And when we begin to look at this gap, we have to really begin to interrogate the leadership, the ethics of the leadership, the knowledge base, what are the gaps between the current existing knowledge that we are generating in perinatal QI compared to what we could be constructing, we could be incubating, we could be disrupting and accelerating if we were to modify our ethics, our leadership, and our science. And also thinking about trust, truth, transparency, and transformation. How do we begin to utilize our ethics, our leadership, our knowledge, and our science to lift up a particular group that is carrying the greatest burden of deaths and near deaths, and really celebrate the innate ways in which resistance and resilience, ways in which Black mothers and people have been rising above these inequities over decades. That for me has been missing, particularly in the ways in which we conduct our business around perinatal QI, and all leading to community participation and partnership, and really moving away from tokenism, decoration, manipulation, exploitation. How do we lift up the leadership, the voices, the lived experiences of our Black mothers and birthing people, our Black women scholars in this work? And then also looking at this, the outcome, the prioritization of the supremacy of clinical outcomes, which again, are mostly rooted in a pathology, as opposed to an experience measure that really would connect across generations, across history, across cultures, to really look at how the process of care is impacting the experience of the care through the lens, the voices, the narratives of Black mothers and birthing people. So for me, it's very important to think, well, how are we defining the problem? And so very briefly, I have been thinking about the way we think about apartheid in the United States, but particularly around reproductive and perinatal apartheid, and thinking that we can no longer deny the historical and contemporary existence of this type of apartheid that does exist in our United States health systems. So in 2018, I then began to think about the meaning, the manifestation, and the mechanisms of action of this particular type of apartheid as a system of racial and ethnic separation, rooted in a hierarchy of value, power, potential, knowledge, and participation based on skin color, resulting in the pursuit, provision, and proliferation of safe, respectful, dignified, responsive, high quality, reproductive and perinatal care and experiences during pregnancy, labor, childbirth, and postpartum for a particular or dominant group. And on this list, you'll see that there are many ways this separation or apartheid exists in various ways that result in differential ways of either access, utilization, opportunities. We're really thinking about differential ways that people get to participate in life, liberty, and the pursuit of happiness. And so that was one way for me to begin to reimagine the problem. And moving on to who were who were the scholarship and the models of ways in which I could reimagine conducting quality improvement research and really being informed and inspired by Dr. Leith Mullins, the late great Dr. Leith Mullins, and really reading her work around how the intersectional oppressions of racialized, gendered, classed ways of exploitation, harm, and oppression, but also looking at the ways in which Black mothers, people, communities come together to act in resistance and resilience. And where was that in quality improvement today? Again, being inspired by Dr. Icahn Davis and obstetric racism. And let me go back, I'm sorry. I must say the sojourner syndrome. And that is, again, the framework that we have been thinking about. That when we look at the data in QI, we see what's happening, particularly in the hospital setting, but we don't bring the histories or herstories of people into the care, but also into the science, into the ethics and the leadership. And then going on with what was missing for me and how I could think about ways to measure experiences. Again, I need to reframe our ethics and our theories. And so therefore, sojourner syndrome and such a racism by Dr. Icahn Davis with the online publication in 2018 of Obstetric Racism, the Racial Politics of Pregnancy, Labor, and Birthing, as well as the 2019 release of Reproductive Injustice. That for me was an awakening and an enlightening moment because I was able to see, and again, as she defines, the mechanisms and practices of subordination to which Black women and people's reproduction, including their preconception, their pregnancy, their prenatal, labor, birth, and postpartum, were subjected to tracked along histories of anti-Black racism, particularly looking at that anti and postbellum period, and where we do believe such racism is a threat to positive births. And so some folks may believe that this approach may be too much for getting at the experiences of Black mothers and birthing people. But when we conducted focus groups in 2019, and this particular mother had not read the work of Dr. Mullins or Dr. Davis, we see how in her own experience, she felt that when she gave birth at the hospital, you push out the baby and then you go back on the fields and you keep picking the cotton. So it is very real in the ways in which the birthing in our hospitals particularly is not only colonized, but is reminding folks of this of experience of slavery or in the afterlife of slavery. So to date, there is no validated participatory patient-reported experience measure of obstetric racism scale that exists that characterizes the impact of the quality of hospital-based perinatal care on the patient experience as defined for by and with Black mothers and birthing people in dignified and equitable partnerships with Black women-led community-based organizations of Black women scholars. So we then decided to think about the Sacred Birth Study, but before going into that, particularly looking at like, what is it that we want to accomplish? So we had already developed the scale based on 2019 focus group interviews that really represents a Black feminist ethnography of the experiences of birthing, the experiences of birth planning, preparation, expectation, and experience, and those disconnects between what Black mothers and birthing people desired versus what they were experiencing. So in 2020, we wanted to validate that scale. We also wanted to bring forth community voices, lived experiences, their intellectual thoughts, their activism into the perinatal QI space by facilitating a virtual quality improvement, generation, and prioritization of things and ideas across the domains, the theorized domains of our scale. And on the left, you see that from our focus group data, our theorized domains, what came out of that really aligns with what Dr. Howe was saying, was safety and accountability, was safety, autonomy, communication information, racism, empathy and humanity, and dignity and Blackness. And 3 additional theorized domains came out of that as a way to mitigate obstetric racism, and that being social networks or kinship. Accountability, this is the actual word that mothers were describing in the focus groups that I did not have to say myself. They came to that conclusion themselves, as well as holistic care. And the third aim was, how do we then, once we have the scale, be able to examine the association between pandemic hospital responses, experiences of obstetric racism, and birth outcomes and experiences. So our whole thing that I want you to get from at least my conversations today and then in the final couple of minutes is we had to reimagine, redefine what power looked like, to be very honest. How do we have facilitate Black women's and people's intellectual thought and their activism in the QI space? So we needed to shift this power that has been usually consolidated to your left on QI experts, clinicians, data scientists, hospital administrators, and shifted to the right to this group of people, Black mothers birthing people, Black community leaders, Black women activists, artists, Black women scholars in the social sciences and public health, which is very important because these disciplines have not been very well valued or their knowledge generated, not generated, but disseminated in the QI space. So on your right, these are our knowledge generators, our guardians, and our disseminators. So in this model of participatory QI science practice and research, again, we named the problem. We know that there's a persistent gap in perinatal death and near death. Next, we need to define that phenomenon. So we define that through Black feminist intellectual thought, through the definition of perinatal and reproductive apartheid, through Dr. Leith Mullen's sojourner syndrome of not only characterizing the intersectional oppressions, but the ways in which we resist, we rise, how we resolve to move forward and activate our power to resist what's happening in not only in society, but also in the health spaces, and particularly in the hospital spaces. And then Dr. Davis's obstetrical racism, really looking at the particular kinds of interactions, communications, counseling, decision-making, and actually documentation that perpetuates the ways in which we've been treating Black people, Black birthing bodies for centuries. And once we named the problem, we defined the phenomenon, we then can be able to propose methods and ways to measure, monitor, and modify the problem through, again, Black women-led serving community-based organizations, through this transdisciplinary, transgenerational scholarship of Black women, through this patient-reported experience measure of obstetric racism, and also through having community come up with social, cultural themes and topics to bridge what is happening in the clinical space with the social space. So in terms of cultural rigor, something that I defined in 2018, and for the sake of time, it does move cultural humility beyond the interprofessional kind of a clinical education space, but really thinks about the ways in which we can operationalize Black feminism, reproductive justice, research justice across these 4 modalities. So as a movement, again, we want to activate Black feminist intellectual thought and activism in participatory perinatal QI. We want to make sure that the lens in which we're looking at the problem, as well as the strides and solutions, are grounded in Black feminist anthropological scholarship. And then the practice, how do we begin to utilize, scale up and expand upon the measures and interventions that would allow us to advance the humanity and dignity of Black people and women in the space. And then the vision, again, is how do we have a sacred birth movement to end obstetric racism in hospital settings? So visually, again, this kind of arc of cultural rigor is translating what has been happening outside the hospital across generations, across time, to bringing that to the hospital space, because it's very necessary to be seen, to be heard, to be listened to be honored in that space. So this arc of cultural rigor brings these frameworks into this space that allows us to really begin to tap into the existing knowledge, a repository of knowledge that's among Black people in the circle that's surrounding the patient. And we're gonna have like popcorn slides for the rest of the time. So this is my group. Researchers, we do represent nursing, medicine, public health, epidemiology, activism, midwifery. The common theme is public health is across all of our formal and informal training. And we did come together to examine safety, autonomy, kinship, communication, racism, empathy, and dignity in Blackness. Again, I need to have to reimagine our images, our messaging, and our communication, which is why I went to Danielle Reed, a Black woman-owned marketing firm. I also have Nikenji Ayana Brown as our curator, and also Cheyenne Varner as our graphic designer, who is also a doula. So again, bringing folks together who have the lived experience of either being a Black woman, but also being a birth worker. With our virtual quality improvement innovations with community, we generated 75 and then prioritized 48 social cultural themes and ideas across the theorized domains of the PREM-OB scale. We currently have 17 hospitals, 2 were added yesterday, 2 health centers, 2 health plans, one national community partner that's helping us in terms of increasing the public visibility and participation in this work. The narratives from 2019, again, helped to shape our theorized domains. One of the Black mothers from Oakland said this, and so to have people of your culture or you share some similar background, it just makes you feel safe, comfortable, received, accepted, no judgment. That helped to inform patient-identified qualitative care domain, safety, and kinship. When we look at other narratives, this particular quote, I feel like they don't prepare you or tell you what's happening if you tear or if you hemorrhage, like that information is not readily available. And so they just take action. And so when it happens, it's very scary and traumatic. And so again, this particular domain or quote is helping to shape the domains of communication and information exchange, autonomy, empathy, and humanity. And there is our skill right now across these theorized domains. And because of the sake of time, I will just share some of the data, but I thought it was very important for us to know who is in our group right now. So when we look at the Black mothers and birthing people, we see that folks are married, living with partners. We also see that folks are single, but also living with partners. So again, being really informed by Dr. Leith Mullins, like what is the totality of the social experiences that people are having in their homes, in their community, in their neighborhoods that they bring to the healthcare space. I think it's also very important to note that at least 60 to 70% of our mothers, Black mothers and birthing people have some college degree or greater. And that's important because when we look at, and I'll keep going, when we looked at incomes, we looked at the total household income before taxes and deductions. When you see on this graph here that at least 1 in 3 Black households with Black mothers and birthing people earn less than $25,000. When 1 in 2 Black mothers and birthing people have an associate's degree or higher, when 1 in 2 Black mothers and birthing people worked 40 hours or more. We did want to lift up the fact that only 80% of our population identified as heterosexual. So it's very important that we recognize the different ways in which people seek pleasure and build family and birth, and that they all are not synonymous to a cisgender heterosexual normative way of being. Heteronormative way of being. We also were able to look at who had parental leave, what length of leave that was. I think it was also important for us to hear from Black mothers the way in which they reported their clinical outcomes, that 1 in 3 Black mothers and birthing people were affected by some form of hypertensive disease. Again, looking at what type of birth people are having, we are excited that 2 in 3 had a vaginal birth. Also concerned that, again, 38% of people are having a cesarean birth. But one thing I wanted to also lift up, that 47 Black mothers had a previous cesarean birth, and 16 of that 47, so 34%, had a successful VBAC. I thought it was also important to, again, thinking about what are Black mothers and birthing people doing in terms of their health and health-seeking behavior. So we looked at these trends, and just for the sake of time, again, we were asking what help did you need, and what was the source of that type of help? Because we want our data to be able to help community and public health systems to facilitate a reinvestment in public health and in community health, because not everyone is utilizing things inside the hospital due to access and lots of other hosts of reasons. But I thought it was important, again, to bring this back to 1 in 2 Black mothers birthing people have an associate's degree or higher. But look at the amount of help that people needed from a lawyer, from food assistance, from reducing violence in their home. And this just shows who completed our scale right now. We are represented in 34 states and DC. You see these 5 red bubbles are all around California, because as of yesterday, 256 Black mothers and birthing people have completed the scale, but outside of California, 377. And I must give a shout out to the South, Mississippi, Tennessee, Florida, New York, you all are in our top 10 as well. Georgia, Texas, New Jersey, in terms of who is responding to this bold movement to advance sacred birth and to dismantle obstetric racism. This is a quote just from a Black mother, again, just really honing in on how the application of the scale gets at to the feelings and the words of what Black people are experiencing as they are served or handled in the healthcare system. And last, I'll end on one of the things that I thought was very important was one of our, we are protected under copyright law and trademarks in terms of the scale. So one of the domains is empathy and humanity. One of the questions was, the hospital considered my life outside of the hospital considered my life outside of the hospital as a Black mother birthing person during their communication, counseling, and decision-making. And I want you to see that 64, so 2 out of 3 Black women almost never or rarely felt that their life outside of the hospital was being integrated into their care. That is not only degrading and dehumanizing, but it's dangerous. And that's why it's very important to have a PREM go alongside your outcome data, so you can see the meaning behind the measures, but also the totality of how the care or the process of care is impacting Black women and birthing people. So in terms of our vision, we want to advance sacred birth to end obstetric racism through human-centered design, grounded in cultural rigor, focusing on the South where the data reside. So we follow the data. We want to test and scale up interventions, including illustrated clinical narratives, effective clinical practice techniques, and more. We want to build hospital community capacity and capability of diagnosing and dismantling obstetric racism through this 2-step process. The first and only validated short and long form PREM-OB scale. And again, what would widespread utilization scaling up look like in terms of having a training, a certification, a licensure, an ongoing TA, because it's very important for me and my community to protect the integrity of the scale and its intended use. And for future data analysis, we can now examine the association of experiences of obstetric racism and fill in the blank. What do you want to know? Birth type, birth attendant, the risk of severe maternal morbidity, hospital religious sponsorship, baby-friendly status, residential segregation, and so forth. So thank you for your time and attention today. Follow us on social media as we continue to share data about how this experience is impacting us as researchers, but also the community and the participants of our study. Thank you so much.
Thank you very much, Dr. Scott. We really appreciate you. This is really important work that you're doing. Now I'd like to introduce the moderator for our first panel, which is entitled Next Steps for Health Equity and Maternal Morbidity and Mortality. The panel will be moderated by Dr. Wendy Wilcox, who's chair of obstetrics and gynecology for New York City Health and Hospitals King County. And she co-chaired, as you heard earlier, the governor's task force on maternal mortality and disparate racial outcomes. Thank you so much. And I'm going to turn it over to Dr. Wilcox.
Thank you so much, Dr. Howell. And thank you so much, Dr. Scott, for a really excellent presentation. I learned a lot and I'm really excited for the follow-up, and thank you so much also for joining our panel. I am truly honored today to be leading this panel of very distinguished and just amazing healthcare advocates and experts in their field. And the way we're going to do this is I'm going to briefly, I know you all have bios, but I'm going to briefly introduce in the order of our panelists and ask them the question. Everyone will have 5 minutes, and then at that time, I'll give a gentle reminder to wrap it up in the next minute so that we can get to all of our panelists and hopefully have some discussion at the end. The first person I'll introduce is Dr. Sasha James Contorelli. Dr. Contorelli is the immediate past president of the American College of Nurse Midwives and the chair-elect of the midwifery program at Yale University. Dr. Contorelli, you've co-chaired the New York State Task Force on Maternal Mortality and Racial Disparities and Governor Cuomo's COVID-19 Maternity Task Force. You have over 20 years of experience in midwifery. Given your experience and expertise in your current position, please share with us your thoughts about where the most significant opportunities exist to address racial disparities in maternal mortality and severe maternal morbidity.
Hi, good morning. Thank you very much for inviting me and having me speak. I really do appreciate this opportunity to share my thoughts and to be here with my colleagues today. So thank you and good morning to you all. I hope it won't take me 5 minutes to have this discussion, but I'm going to focus on a few areas, and I'm glad we had the introduction from Dr. Howell and Dr. Scott. And I want to focus on history, education, and an increased workforce to really have sustainable change and touch on these points. So number one for me to really make sustainable change for maternal mortality and severe maternal morbidity in this country is to examine the history of birthing, particularly for Black and Brown women in this country, and understand how this has framed today's narrative. And that's just underscoring what Dr. Howell and Dr. Scott presented on. Then number two, to truly integrate that historical perspective and data into current education. As a faculty member at Yale, and I've been in education for quite some time now, and also practicing midwifery, you understand that as you frame the minds and try to help and share, impart knowledge to our upcoming generations, they truly need to understand the historical perspective, and in order to understand how patients and people present in spaces as they are seeking care, to continue to cultivate truly an interprofessional education, promote with midwifery and midwifery education as a means and a pathway to integrate into our healthcare team. That will increase your workforce, increase your options for patients as they seek care as women and birthing folks in the United States, and lead to then a sustainable change as folks are able to experience different birthing areas, options for birthing, the ways in which we as Black and Brown folks, and I identify as a woman, so I will say women, because that's important to me from the historical perspective, the ways in Black and Brown women experience birth in this country. So those for me are my 4 top areas. I will then turn this back over to Wendy as we listen to other panelists. Thank you.
Thank you so much. And next we're going to go to Chanel Portia Albert. You are the CEO of Ancient Song Doula Services, an organization you founded as an international doula certifying organization with the goal to offer quality doula services to women of color and low-income families. You have national and international experience in public health and serve as a maternal health strategist. You are a consultant on birth justice and provider engagement for New York City Department of Health and Mental Health. I'll ask you the same question. Given your experience and expertise in your current position, please share with us your thoughts about where the most significant opportunities exist to address racial disparities in maternal mortality and severe maternal morbidity.
Thank you, Dr. Wilcox. It's a pleasure to see you. Greetings and good dawning, everyone, wherever you may be. I am on the East Coast, so I'm going to say good dawning because it is very early. I want to first uplift the work of Dr. Howell and Dr. Scott. You both led beautiful presentations that really laid the foundation for what I'm going to speak about. And it really hit me when Dr. Scott said trust, truth, transparency, and transformation is something that is needed in order to really center what I believe is hope. Hope is something that is really missing. And so I'm going to share my screen so that I can share my presentation with you all. So I'm going to speak briefly about the intersections of hope and maternal health. And I think that one of the things that's really missing within the framework of maternal health and really having conversations with individuals who are in community, centering individuals' lived experiences, as well as transforming systemic changes institutional-wide across the healthcare system, is that we are not putting enough effort towards what does it mean to center hope within the work that we do every single day. And so how that continues to show up is with the trauma that is continued to be perpetuated in the lived experiences of the individuals, but also in the providers that are providing the care and these conditioned responses. And they're centered in adaptive behaviors that have served to protect oneself, their child, their family members, or community during a traumatic occurrence that becomes normalized trauma responses and internalized as normal behaviors or cultural identity markers over time. And I bring that up because a lot of the ways in which Black birthing experiences for pregnant people, as well as providers, are based on these conditions responses of how do I try to work within a system that was not structurally set up to support me in my experience, not only as an individual who is seeking out care, but also as one who is providing said care. What we need to understand is that the heart of justice is truth-telling, seeing ourselves in the world in the way that it is rather than the way that we want to be. And I think that starting from a foundation of telling the truth and speaking in that, as Dr. Scott said, trust, transparency, truth, and transformation allows us to be able to really start a framework to be able to pivot off of as a catalyst for change when we start to talk about systemic racism, institutionalized racism, not just on the forefront of the patient-centered experience, but also across the healthcare system in general, right? Really tapping into the ways in which people are able to disseminate information, receive information, but also utilize that information on a daily basis. The theory that I have conceptualized centers on intergenerational hope. And it's at the intersections of transgenerational messages passed down through cultural, familial, language, justice, love, purpose, ancestral remembrance, and resilience. And it's triggered by a commitment to center joy, self-care, accountability to self and community, the decolonization of systems of oppression, and the liberation movements that center intersectional perspectives as how people care for themselves. And we don't honor the ways in which people care for themselves in ways that are tangible, really within the healthcare infrastructure. And by centering methods set up and established by Dr. Scott, Dr. Howell, Dr. Davis, Monica McLemore, and others, we are really starting to see how intersectional perspectives of how people care for themselves are important in service delivery, but also in the receiving of that care and how it's interpreted. We understand that intergenerational trauma of the experiences of maternal death, the Middle Passage, police brutality, food apartheid, Jim Crow, internment camps, racism, bias, a pandemic, how that intersects with how someone is experiencing something where you have you yourself actively addressing the present, you're building on the future, and you're trying to center the past. And so intergenerational hope reminds us that as we're doing this work, as we're sitting here and we're providing care, we're looking at these remedies for how do we decolonize the frameworks that have been put in place, that we're doing that through reclamation of our ancestral practices, reclaiming midwifery, establishing mutual aid, having anti-racist medical models of care, the decolonization of systems of oppression, children and families and communities being able to be centered first when we're providing and looking for care, centering laughter and self-care and mutual aid. because we are wanting the feeling, but don't want to give ourselves credit for feeling the feelings. And I think that we have to give ourselves credit for the feeling of that every day that we put ourselves forward in this work, we are centering hope and identity and love and courage, and we're breaking down that intergenerational trauma that has been perpetuated for so long. And in that work, we honor the feeling of the lived experiences, the understanding that your feelings are valid, even rage, when breaking, learning, and moving through that trauma. It also honors the practice of doing sometimes while in transformation, we don't realize how far we've come. The act of self-reclamation and liberation, so reclaiming liberatory practices that center a whole, not just the parts of who we are. That encompasses a remembrance of ancestral practices, the creation of new practices that center not just individuals, but entire communities as we move through these frameworks. And it is the past, the present, and it builds on the future. And that's the understanding that the intergenerational, but also transgenerational, and it acknowledges the intersectionality of self, of family, and community. And until we really understand and we really acknowledge the intersectionality of self, family, and community, we can't pivot towards accountability measures and ways and means to be able to really center individuals and in the work that we do. So as Dr. Scott said, which I thought was like amazing presentation, that we must stand strong, right? We're standing strong in the hope of our ancestors while manifesting hope of our present and building hope for future generations that builds on centering and accountability to all Black and brown birthing bodies in our communities and the work that we do. And so that is, primarily what I wanted to share. I think that a lot of times the conversations that we have are really centered on what's going wrong. And we understand that framework and it is important, but we also have to uplift the courage and the work of the individuals who are shifting the catalyst of the conversation in research, in data, and looking at, community-based work that is being done on a level that's sometimes being done in silos that people are not seeing, right? Acknowledging the work and understanding that it is done in the presence of really wanting to center hope, moving from trauma-based theories and approaches that are reactionary and moving towards future generational hope that is building on sustainability, action, and movement building. Thank you.
Thank you so much. Yep. Amen. Next, we're going to go to Dr. Natalie D Hernandez. You're an assistant, Dr. Hernandez, you're an assistant professor at Morehouse School of Medicine in Community Health and Preventative Medicine. You're interim director for Medicine Center for Maternal Health Equity, and you're a postdoctoral fellow at the Prevention Research Center and Center of Excellence on Health Disparities. You serve on the board of directors for Georgians for a Healthy Future, a nonpartisan, nonprofit consumer health advocacy organization. So the same question is given to you, given your experience and expertise. Please share with us your thoughts about where you feel is the most significant opportunity to address racial disparities in maternal mortality and severe maternal morbidity.
Thank you so much, Dr. Wilcox, and it's just great to see these amazing panelists that I get to share the stage with, and I'm just so grateful to be here. Just to give you some context, because I know we've heard a lot of information and data about what's happening in New York, but as we know, Georgia is currently ranked last place, or at least 48th in the US for maternal mortality. And the maternal mortality rate among Black women is even higher than the national average. Black women are 3 times more likely to die of causes related to pregnancy. And in particular, what's often forgotten too are the rural communities. The rural communities in Georgia are significantly Black, and Black rural women face distinctive challenges, including shortage of hospitals, doctors, disproportionate rates of poverty, and persistent structural racism. Half of all Georgia counties lack some type of obstetric unit. And so women are just sort of scrambling to get the care that they need. And there's a legacy of racism. There's legacies of racial discrimination, income inequalities. There are some places in Atlanta where just 2 miles away from one another, where the inequities in your life expectancy is about a 30-year difference, and it's just glaring. To address a lot of these maternal health inequities in Georgia, the state appropriated funds to establish a center of excellence addressing maternal morbidity and mortality, and we thought it was important to change that to be a center for maternal health equity. Our vision is to end inequities in women's health across the lifespan, and we do this through translational research aimed at advancing the understanding and reduction of maternal morbidity among BIPOC women and other underserved populations, interprofessional training of future leaders across the workforce continuum, outreach and community engagement, policy and advocacy, and innovative, respectful healthcare. What we see as an academic institution and how we see ourselves different is that we always ensure that our work centers the experiences of Black women as an opportunity to rethink conventional research practices. We acknowledge that the women's lived experiences are legitimate sources of knowledge. And additionally, we ensure that we also center BIPOC researchers, because although they have the knowledge, they are often left out of the table or brought in some type of advisory capacity, knowing full well that they can lead the research. Additionally, as my colleagues stated too, a lot of research is focused on deficits, and we strive to use a strength-based approach to what we do in our work. There's a lot of really great stuff happening in Georgia since being established. Our faculty and staff at the center have been instrumental in leading a lot of local and national community engaged initiatives to address maternal health inequities. We established a maternity mortality stakeholder group, which was instrumental in extending postpartum Medicaid to 6 months in the state of Georgia. And at the same time, Georgia had cut all maternal health initiatives. They didn't feel that women in the state were important, and we were able to restore that funding to all of the maternal health initiatives that were initially cut. In partnership with Johnson & Johnson's Health of Women team within the Office of the Chief Medical Officer, we also established the Georgia Maternal Health Research for Action Steering Committee. This steering committee brings together researchers, clinicians, policy experts, and community leaders to align on inclusive, actionable, sustainable, and scalable evidence-based approaches to improve maternal health outcomes for Black mothers in Georgia. We're also working on creating what we in Georgia feel is our definition of maternal health equity using a Delphi process of consensus building. Last year, we received funding from the National Institutes of Health, from the National Center for Advancing Translational Sciences to establish the Georgia Improve, which is implementing a maternal health and pregnancy outcomes visions for everyone. We're getting together a stakeholder community-based perinatal care research and intervention network to conduct sort of a statewide needs assessment with women, healthcare providers, and health systems. And lastly, our team leads on a lot of different statewide boards. Right now, we are embarking on creating the largest repository of Black women's stories. We will be conducting 160 interviews with Black women across several states. I just received funding for my research, which is also focused on the framework is the Sojourner Syndrome and the Maternal Morbidity Framework, where we be developing a mobile application to assist women in that transition period from discharge. And then because we're a medical school, a huge thing is the training of our providers. And so how do we do that? We have created a respectful maternity care simulation project with my colleague, Dr. St. Louis. We have been conducting a lot of trainings around, and Dr. Scott alluded to this, communication training and team-based approaches. How do we work on this? A lot of our doctors, although, we have, we're creating a large set of Black physicians, even our own people don't know how to communicate with our own populations. And so how do we do that? And then always continuing to be in the forefront of advocacy, because we cannot accomplish anything if we're not there talking to our legislators, making sure that initiatives are supporting our women and are being, and being held accountable for their actions. So I'll stop there, but that's sort of what we're doing, because I know a lot of people don't know about Morehouse School of Medicine Center for Maternal Health Equity.
Thank you so much, Dr. Hernandez. And so what we're doing as part of this panel is really learning about the experiences. We've, from California to Georgia, we already heard about the New York experience. And now we're going to hear from Dr. Allison Bryant, Dr. Bryant, you are a maternal fetal medicine specialist and vice chair of quality, equity, and safety at the University of Massachusetts, where you work toward equitable care and outcomes for all patients. You have your degree in public health, and therefore, and before you became faculty at Mass General, you are in faculty at the University of California, where you served on the advisory board of California's Black Infant Health Program and the San Francisco Department of Health Women's Health Advisory Board. Same question posed to you right now, given your experience and expertise in your current position and past. Please share with us your thoughts about where you think are the most significant opportunities to address racial disparities in maternal mortality and severe maternal morbidity.
Great, thank you so much, Dr. Wilcox, and good morning, everybody. I'm so honored to have been invited to present amongst really such a group of esteemed colleagues. I will say I'm also a native New Yorker, so I'm grateful to be home, even if it's just virtually. That means I tend to talk very, very quickly, so I apologize if I am speedy. So this morning, I think I was just going to talk quickly from sort of two vantage points. So one, a perspective that I'm going to bring as sort of an OB care provider and a leader in a healthcare organization at Mass General Hospital. You heard earlier from Dr. Howell's presentation that a significant proportion of inequities that we are experiencing are attributable to the care that is provided. And as a provider, I really acknowledge the fact that we work within a healthcare system that is in no way designed to put equity first in its current state. And so as someone, I've come to sort of think of someone who tried to be systematic about how we can elevate the equity conversations in the healthcare provision setting. And secondly, I'll sort of talk briefly as my perspective from the perch as the chair of the Massachusetts Maternal Mortality Review Committee. I've tried to bring an equity focus to that group as well. So from the provision of sort of my perch as the vice chair of quality, equity, and safety, really, I think in the healthcare space, we really have to actively build a culture of no quality without equity, and encourage really everyone who works in our organizations and who really purport to care about care quality to do the same. So we cannot, as an organization, talk about our low cesarean delivery rates or our high VBAC rates or our low postpartum hemorrhage rates without talking about which groups enjoy that privilege and how we can make sure that all of the groups that we serve enjoy that privilege. It just doesn't make any sense. I think we recognize the value and the sort of power of all frontline providers and staff to impact the care and the experience of every patient from the moment the patient sets foot in the healthcare system or even beforehand. And so one of the things that we've really tried to do is to raise the awareness of inequities in the care that we provide across all of our role groups. And so to that point, we really do review all of our aggregate and stratified data for all of our quality metrics in disparities dashboards that we present to our OB staff, our OB nurses really on a monthly basis. So here is our hemorrhage rate this month, but here's what Black women experience in terms of their hemorrhage and why does that look different than our white women. We also lead all of our retrospective case reviews when we talk about M&M or quality assurance. We lead those conversations, those case presentations with the race, ethnicity, the language concordance, the insurance, and the social determinants of health of the woman that we are reviewing. So I might say that this is a 31-year-old Black, English-speaking, publicly insured woman who has food insecurity, and this is the thing that happened to her, so that each time we can come back to those metrics and understand the role of those demographics in sort of the care that was provided to the patient and the outcome that she may have experienced. We also are trying to really facilitate some anti-racism work within our physician corps and our nursing corps and our front desk corps. So really answering the question of how does race show up in the work that we do. One of the things that we heard from our providers is they wanted to have a space where they could talk about the experiences that they were having in their daily basis. And so we've created something that we call the Inequity Inbox, which is a sort of anonymous place where anyone who works within our field and our department can report a microaggression, discrimination, bias that they witnessed that happened to them or that happened to a patient. And that has been brought back to our groups to understand the things that people deal with on a daily basis so that people who may not experience those things understand how that shows up at work. We clearly know that we need to do better in terms of understanding the experience of our patients. And so we are very grateful to Dr. Scott and her work and the work that is coming so that we can capture that and feed that back, because we've done not as good a job at sort of listening to our patients. And then just really briefly from my role as the chair of the Massachusetts Maternal Mortality Review Committee, it is an honor to serve in that role. And I think that we all have a great respect for what we have to do in terms of understanding the very root causes of death inside or adjacent to pregnancy, especially for birthing people of color. Dr. Howell described earlier the CDC work that was to create established and agreed upon definitions of constructs like discrimination, interpersonal and structural racism. And I'm so grateful that those sit aside things like obesity or medical error or substance use in the forms that we use to establish what are the contributors to death of a given woman. I think we definitely need to improve how the committees and how the abstractors come upon that information, and that's work that needs to be done. And then ultimately we need to take that and sort of make recommendations for how we can improve the care that we provide to women, learning from the stories of women who have had adverse outcomes. So I'll stop there and happy to answer questions later if we have time in the Q&A.
Thank you so much. I really appreciate that. Dr. Scott, back to you. There are a lot of questions. I've been kind of monitoring the questions in the chat box, and definitely people are curious and very excited about your Prem OV. And so there are some questions about how people can get access to that, whether or not they were able to use it for actual patients. And if you could also give some more concrete, perhaps steps that people can use in their own arenas to help bring out the voice of the patient to increase equity.
Thank you, everyone. I was all into what people were saying. So, step one, so you can, the study currently is still live. So if you go to, it was on my slide. I don't even know if I can still put it up briefly, maybe. If you can see right now, if you go to sacredbirth.ucsf.edu, and then I'll stop sharing, anyone can go and refer or do a self-referral or provider friend referral. I get emails. Just yesterday, someone was like, my friend gave birth at the end of December. Can they be a part of it? So one can go online, the self-screening consent, the enrollment, and the final survey completion are all virtual because we started the study in a pandemic. That's number one. So the scale is protected though. So I'm going to be very transparent. I do want to maintain the integrity of the scale. So we are not releasing it publicly. We're in the process of validating, and validating is not validating the experiences of Black people, but it's validating the instrument. So the science behind the instrument, making sure that the survey questions will actually give us the data that we need to be able to examine, again, what Portia's saying, what everyone's saying, it's the words, the feelings of care. And in medicine, we've learned to put feelings as subjective and go and right, like in the way we assess and how we document our work, subjective and objective. And that really has been the crux of what we're doing. So my recommendation, what you can do now, where are patients? Like when you look at your data, even if you have one Black patient or one Indigenous person or woman, or one person of color that delivers to your hospital, what's their experience of care? And we don't know unless we ask. And it's not a satisfaction. It is about the impact of the process of the care. Meaning, if we are continuing to ask Black mothers and birthing people particularly, are all children his? Is he gonna sign the birth certificate? Like there's these questions around fatherhood that are degrading and dehumanizing, when the equity question, the equitable question would be asking, what do you need from us as a hospital team during your hospitalization to parent optimally before you go home? There are low cost, no cost things you can do in your hospital, in clinics and offices now. Just stop using language that reinforces and reproduces harm, period, whether it's be racist, sexist, classist. And so really thinking about what's the impact of our care, and we don't know unless we ask. And so bringing Black mothers and birthing people together on a committee, on your maternal mortality review committee, on your IRB.
Yes, understood. Thank you so much. And we're going to do a very quick round robin because our time is running out a little bit, but more than one of our panelists really brought up the role that we play in ensuring that our learners who are coming up do not come up with this racialized lens that so often is not addressed before one becomes a fully fledged midwife, doctor, nurse, etc. So there's so many of you on this panel who are actively involved in education and in in educating our learners. And so to you, I'll just go in the same. Dr. Contorelli, please let us know your thoughts on that.
Thank you. So education is, from a child and as a child of a West Indian family, education has always been the foundation of, it's so important. It's been seen for people of color, our means of moving forward and advancing and breaking down some of the stereotypes and barriers that have been placed on Black and Brown people in this country. So for me, attaining education and being able to impart that for future generations has been at the forefront of my brain. And as a clinician, how do I know, having the knowledge that I had to find on my own, seek on my own, about why is it that Black and Brown women that look like me present in spaces, how they present, and what are the barriers that they're facing, not only when they present to me, but when they go back to their own community. And how do where is that gap that I can fill to impart that to the learner that's coming and alongside me as I, in a clinical arena and also in the classroom, what are some of the subtle, the nonverbal cues that we as Black and Brown women and birthing people give off or exude to other Black and Brown women when we as practitioners, when they present in spaces, that look of, thank God it's you, that look of, I'm so happy I can actually open up to you, someone that looks like me, and that feeling of safety. How do I impart that to my students? And how do I train other professionals, not only midwives, nurses, but physicians that I encounter, social workers? That is so important, and at the crux, and that can be the change between them having being traumatized and having a horrible birthing experience, and them having an optimal outcome and feeling good, and even going on to reproduce and have other children and be successful when they go home.
Thank you. And I know one of the outcomes of our, you were co-chair with me on the governor's task force, and one of the outcomes of that was to, and I'm not sure if it made it to the report, but really was to try to fund and get more Black midwives, to train more Black midwives. And how do we go about doing that so that they are attracted to the field and we get rid of the historical racism that has existed along that track? Turning now to CEO Portia Albert, do you want to talk about training a minute? If I'm going to give everyone a chance, because it's 10:20, we're going to a little bit over, but everyone can have a minute to try to address this.
Yeah, definitely. So I would say, as someone who teaches, I always tell my students, meet people where they are, not where you expect them to be. And I think that is the foundation to really centering like what a patient-centered relationship looks like, understanding that you are coming in as a provider with your own lived experiences. The individual patient is also, in understanding that that looks very different based on the perceptions that we have been fed through social experiences, social media, etc. As someone who mentors and has trained medical students at Columbia and other places, and I'm doing that now, I think it's important for them to understand the historical implications of what does it mean to serve Black, Brown, and Indigenous bodies, on not just understanding cultural identity, but also being very humble about that, right? What does it mean to come from a framework of cultural humility, excuse me, where you're understanding that you may not understand, and that's totally fine, right? But it's about the shared experience of being able to be in community with that person, and understanding that as they go through their experience, you too are learning something from them. Acknowledging the different intersections of things that can come up, such as, literacy level, level of ability, language, all of the different variables, housing, all of those things play a role in someone being able to access care. I think that when we start to not just look at the parts, but the whole of the individual, then it becomes easier for us to disseminate care in a way that really centers the patient and the provider, right? Because we also have, I think a lot of times we leave out of the framework, and someone mentioned in the comments about, well, what about the people who are providing the services? We don't think about the internalized trauma that they've experienced that becomes normalized behavior that they continue to perpetuate on patients. And so in doing so, again, meeting people where we are, centering that hope and that identity of that individual as someone who is a provider of color who's providing that same service, right. Understanding that you're learning that language of a colonized educational system, and so really having to be intentional about seeking out spaces that uplifts like our human rights framework, bodily autonomy, understanding people like Donna Anai Davis and Lynn Roberts and others, who have wrote these books. Talking about, obstetric violence and racism in medical care. What does it mean to like really educate ourselves and understand that it's continual? It's not something that just happens as a one-off.
Agreed. Thank you so much. And then Dr. Hernandez and then Dr. Bryant, I'd also like you to respond, please.
Absolutely. I think it has to start even earlier. We have a pipeline program at Morehouse School of Medicine where we start training at the elementary level and having these types of discussions. And so I think starting from there, no matter what field you go in, because as other panelists mentioned, it's just not about medical, it's about the structural processes, the political processes that affect how our women are being treated. And at Morehouse School of Medicine, we have these programs at our medical school that are mandatory. So our students come in their first year of medical school where they have to take a community health course that discusses the social determinants of health, that has them in the community, working with community, in a bi-directional relationship, no white coats, just who you are and solving these issues. And so we're really grateful for that. And we're starting to implement that at the very beginning with a lot of our schools in Southwest Atlanta to start discussing these types of issues.
Thank you so much. And Dr. Bryant?
Yeah, so echo a lot of what other folks have said. I mean, I do think it's going to be so important also for us to think about diversification of the workforce. We know that sometimes, communication and can be sort of richer when there is race concordance within a dyad. But I also think as we are doing that, it's not just about the numbers, it's about the experience. I think that what we have learned is that as we bring numbers of underrepresented minorities in medicine into our medical schools and into our residency programs, we need to make it a better experience than we have done so far to make sure that we are protecting people. I think there's a lot to be said about the didactic training that folks are getting, but there's also sort of nothing that's different than sort of modeling at the bedside. So modeling behavior at the bedside. How do I counsel my patients of different backgrounds? And then lastly, I will just say that there is a lot of 360 learning. These learners, this generation is teaching us so much and sort of pushing us in ways that we didn't think that we could do. So I'm grateful to them as learners.
And I am grateful to all of you. And I would also posit that while Dr. Hernandez said it starts in the pipeline and perhaps as early as elementary school, I definitely think that it's something we need to definitely take into consideration when we are interviewing people, and it needs to be part of the admissions process, correct? But I'll just put that editorial comment out there. But anyway, I would like to thank each and every member of this panel. We all gleaned so much from all that you said, and it's quite an honor to lead such a group of esteemed colleagues. So thank you. And I'll turn it back over, I believe, to Dr. Howell.
It's actually going to be to Dr. LaRocque, Arena, but thank you. And I just wanted to echo, no problem. I want to thank all of the panelists again, and the moderator. Thank you for such an inspired conversation.
So yes, I'm not sure about all of you. I see there are more than 400 of you on this webinar. So I want to thank not only the panelists, but also all of the participants. And while we can't have it as interactive as we would like, I want you all to take a deep breath now. I don't know. That's what I've been doing and reflecting on what it is that we are seeing. So first of all, this is just the beginning. So remember that the framework for action in my slides, and I do apologize, I'm not sure they projected well, but it doesn't matter. The framework for action is what we're talking about here. What are bold actions, accountability, and I'm taking words from what you've said, centering hope, no quality without equity, feeling is care, the intersection that we live as being Black and brown women and Black and brown physicians, nurses, midwives, doulas. So I want you to take a deep breath, and we're going to switch our attention to have you share with us your thoughts. Okay, a couple of announcements. One is we do have a hashtag maternal health equity that you can participate in. Social media is really important in communicating our efforts, so we would like you to join that. We have had some questions about the slides. Yes, yes, and yes. This is a dissemination conference, so we will share with you the data that we have. I double checked with my colleague, Liz Howell, and all of the slides. We will share those slides and post them so you can use that information to really continue this effort. So what I'd like you to know is that we're posting here, you see the link, and you can cut and paste, and it's also listed, I believe, in the chat. We're going to ask you to click on that link to take a look and take a moment to share your thoughts and respond to 3 questions that will be posted once you go on that link. Please note your responses are voluntary and anonymous. And yes, we did go through the IRB. The NIAM IRB has reviewed and approved this research survey that we hope will lead to an action agenda to address maternal mortality and severe maternal morbidity. We will have a second reflection time. So I want you to take a deep breath, try to, as I'm doing myself, of processing the information that you receive, both the qualitative and the quantitative experience, and then hearing from ourselves the things that we care about and the women and children we care about, and answer those questions that will help inform us. We do have an evaluation piece to this, and we will continue to disseminate and communicate. And I mentioned the work group that is formed at NIAM. We will take this action agenda to continue the work ahead. We will not want to be 100 years from now, or even 2 years from now, in the same place. We must make a change in the outcomes. So please go ahead and take a look, take a deep breath, stand up if you've been sitting down, and then please answer all of these questions. And again, we are more than 400 of us, so this is really vital information from you. Thank you.
I just wanted to add that we're going to be giving you 10 minutes to do this exercise, and we won't be starting again with the presentations until 10:40. Thank you.
Thank you, Dr. Howell.
Hello, I think we are going to now move on to the next phase of our discussion that will be focused on infant health equity. And I am going to start the conversation by sharing my screen. I don't know if who is sharing their screen, but somebody's sharing, excuse me, and I can't get on. So whoever that is, if you could stop sharing and allow us to get back on, that would be really helpful.
Yes, that should be Joey because he was sharing the link. Okay, so Joey, if you would turn off your share.
Great.
Yes, I stopped sharing.
Thank you. Okay, so welcome back. We're now focusing on the infant mortality disparities that we're all so well aware of. And as I mentioned earlier, Black infants in the United States are more than twice as likely to die as compared to white infants. Again, that's a death within the first year of life. We know that there are numbers that are sort of vary across the country. This disparity is a little wider in New York City at 2.5 times. I want to remind everyone that when we're thinking about infant deaths and this disparity, that it's primarily driven by the fact that Black women are much more likely to deliver preterm births, or what we call very preterm births, which occur at less than 32 weeks. And here's a slide from the CDC, and on the left, you can see that very preterm births only account for 2% of all deliveries, of all infant births. However, they account on the right-hand side of your screen for 53% of all deaths, infant deaths. And being born very preterm is 3 times more common among Black infants than white infants. So you can see that this is a large driver of these intractable infant mortality disparities that our country has been wrestling with for decades. But death is really just the tip of the iceberg for very preterm babies. Similar to what I told you about in the context of maternal health, very preterm infants face a number of significant morbidities: respiratory, neurological, and neurosensory. These are associated with neurodevelopmental disabilities, and these place these infants at a disadvantage over the life course. And similar to what we heard about this morning for moms, racial and ethnic disparities exist for very preterm birth morbidities. So the study that I'm going to talk to you about is the study that, again, funded by NIH, and very similar to the format of the study that I spoke about earlier this morning, with 4 phases. A first phase was quantitative, to examine hospital risk-adjusted very preterm birth morbidity and mortality, and then the racial and ethnic distribution of deliveries in New York City hospitals. Second phase are qualitative interviews to examine safety culture, quality improvement that can explain the variation in hospital performance. The third phase was focus groups with mothers who actually had delivered very preterm infants, and also their babies had a prolonged NICU stay, to explore patient barriers to receipt of high quality care. And then dissemination efforts to increase uptake of best practices. And that's what we're doing today. I wanted to take a moment and just sort of help you understand where and how we thought about the theory behind this mixed methods approach to studying this problem. We use something called positive deviance. And the idea here is you get a community and you identify the top and the lower performers. You conduct in-depth qualitative analyses to generate hypotheses. You test the hypotheses, and then you promote uptake and dissemination of best practices. And essentially what we're trying to do is learn from hospitals that do well, that have low rates of very preterm birth morbidity and mortality, and sort of share those best practices with other hospitals in New York, as well as across this audience. So our first phase was taking birth certificate data or vital statistics, and we linked it with discharge abstract data for all births in New York City over the time period. We used mixed effects logistic regression to calculate risk standardized very preterm birth morbidity and mortality for each hospital. We ranked hospitals on this metric, and we assessed Black-white differences and Latinx white differences in birth hospital and birth location. So this is a bit of a busy slide, but I just wanted to give you a brief overview of the method. So we didn't just look at death. We looked at morbidity, a combined outcome of morbidity or death. The morbidities that we used were any morbidity, and they're listed right here, of NEC, IVH, BPD, retinopathy of prematurity, which are significant morbidities that really impact the development of very preterm infants. We also used neonatal death for up to 1 year in hospital or as our outcome. And similar to what I spoke about this morning, we did a risk adjustment. We adjusted for sociodemographic characteristics, clinical and obstetric factors, maternal comorbidities, and infant characteristics. So here are the overall rates of very preterm morbidity mortality. Again, this combined composite variable that includes death or one of those four morbidities that I talked about. And you can see that there are racial and ethnic disparities, with Black infants, very preterm infants, having rates that are higher than Latinx, and then again, higher than white infants. So we ranked all of the hospitals, and there were 39 hospitals in New York City during this period. And we ranked them based on their risk-adjusted rate of very preterm birth morbidity mortality. And similar to what we saw when we talked about hospital performance for moms, we found wide variation for hospital performance for babies as well. 6-7-fold variation across New York City hospitals. Again, these are adjusted rates, adjusted for patient case mix. We divided the hospitals in tertiles, and we had the low morbidity cluster, the medium morbidity cluster, and the high morbidity cluster. And you can see the adjusted morbidity rate there of 0.16 or 16%. You can see what it was for medium morbidity and high morbidity. So you can see that there was quite a significant difference in the morbidity mortality for each of the clusters that I'm speaking about. But what was really interesting was that there was no racial and ethnic disparity within the cluster. So Black, Latinx, and white infants born in a low morbidity hospital all had the same morbidity mortality rate. That held true in the medium morbidity cluster. It also held true in the high morbidity cluster. So again, no within a cluster differences by race or ethnicity. We then looked at the distribution of deliveries by race and ethnicity among these hospital groupings. And as you can see in this slide, of all the Black very preterm infants born during this period on your left, 20% delivered in that low morbidity cluster of hospitals, while 21% of white infants delivered there and 25% of Latinx infants delivered there. That's in stark contrast to the high morbidity cluster of hospitals, where you see that 43% of Black infants delivered in those high morbidity mortality clusters, while only 23% of white very preterm infants delivered in those hospitals and 29% of Latinx. So we wondered, well, what was that? How might that impact the observed disparity, and how might we think about how much of a difference does delivery hospital or where that baby is born make? And we did some simulations and found that up to 40% of the Black-white disparity for very preterm birth morbidity mortality and 30% of the Latinx white disparity in this outcome was due to hospital of delivery, birth hospital. So next we did the following phases of our work. Phase 2 was hospital qualitative interviews with both high and low performing hospitals, with a range of hospital physicians and nurses and others. We did focus groups with moms of very preterm births to explore patient barriers, and then this dissemination phase. And again, in terms of the hospital interviews, you can see that we thought about, when we came up with our questions, we thought about sort of the structural characteristics, the personnel, attributes, qualifications, equipment. We thought about organizational factors, culture, leadership, promotion of evidence-based practices, communication. We thought about clinical processes, and then we thought about patient outcomes. And again, we layered this with questions around just knowledge and thoughts on disparities, bias, diversity, and then parents and how they were treated in the setting of the neonatal intensive care unit. As I mentioned, we had ranked the hospitals into these three groups of low, medium, and high risk standardized or risk adjusted very preterm birth morbidity mortality. We selected 4 hospitals from the high morbidity group and 4 hospitals from the low morbidity group, again, with this sort of positive deviance framework to see if we could have some shared learning. And we used additional criteria, again, in terms of volume of deliveries, percent Black, percent Latina, and percent Medicaid. We had 8 New York City hospitals, a total of 44 interviews, again, occurring in 2017 and 18. Respondents were consented and the interviews were audio taped and transcribed. The qualitative research staff was blinded to hospital ranking. And we also toured the physical layout of the NICU. Here is a summary of the hospital interviews, and you can see that we spoke to the NICU directors, quality and safety lead for the NICU, nurse manager, frontline nurse. We also tried to speak to respiratory therapists, spoke to chief medical officers, and some other folks, such as the director of pediatrics, et cetera. Again, the way that we approached these analyses was similar to what we did for the MOM grant, where we divided hospitals into 2 clusters. Again, the qualitative team was blinded to hospital performance. They analyzed the themes by cluster without a priori knowledge about performance, determined the overall themes, distinguishing themes, major versus minor themes. And then the final step was for the research team to interpret these findings with the knowledge of the actual performance. So some of the themes, what was really striking is a lot of the themes were quite similar to what we found when we talked to hospital folks around maternal morbidity and mortality. But there were a few things that were obviously distinct. These are the themes that were shared by both high and low performing hospitals. Parents included on daily rounds and providers aimed to engage families, and there seemed to be a commitment across all the NICUs. There also, we found this in some of both groups of hospitals, that sometimes providers were characterizing parents based on the amount of time they were spent in the NICU, substance use, a bunch of other attributes, which they even acknowledged might be causing differential treatment by physicians and nurses. There were universal nurse staffing concerns. Again, there was wide variation in quality measurement and improvement across the neonatal intensive care units. Not only the metrics used and the staff assigned specifically to quality and safety, though many of these NICUs did participate in the Vermont-Oxford network. No one analyzed data at that time to compare performance across race, ethnicity, or insurance source. The distinguishing themes for high versus low performing hospitals, we found that high performing hospitals were more likely to have access to 24/7 neonatologists, better nurse staffing ratios, more emphasis on supervision of residents and mid-level providers, more focus on sharing performance data with nurses and other frontline clinicians. Senior leadership was involved in day-to-day activity, and similar to what we found for moms, there was more awareness that disparities and racism may be present in the hospital and could be leading to differential treatments. And this was really very much directed to the parents, obviously the family of the infant. We also did 3 focus groups, again, with mothers who had delivered very preterm infants or infants weighing less than 1,500 grams, whose babies had a prolonged NICU stay. And we explored how women experienced care. And what we found was that many of the women in all 3 groups spoke about the challenges of their experiences with NICU care, distress from the birth experience, many of them were high risk, concern, deep concern about infant prognosis, and the struggles of parenting in the NICU and the separation. What was interesting is they mostly were favorable about quality of care. They spoke about the importance of communication and preparation, but small sample, but most of the women in all 3 groups felt strong communication. They felt that the staff fostered trust and mitigated the feelings of blame. However, the Black and Latinx groups did talk somewhat about differential care, mostly in the form of suboptimal communication, sometimes being spoken to in a dismissive manner. And also of note was the discouragement of patients' use of language other than English. So I'm just going to leave you with a couple thoughts about, I think, some of the things that we've learned, some of the things that others have learned. And I worked on a paper and a thought piece with Dr. Horbar, who you're going to be hearing from next. And I think it's sort of a broad overview of thinking about how we might tackle this area. But implementing disparities dashboards and utilizing quality improvement tools to address identified gaps in care. Again, providing education on decision-making, communication, talking to parents and integrating them and making them feel part of care and understanding context of where parents are coming from, implicit bias training, educating staff on very preterm birth disparities, focusing on NICU to home transitions and making sure that all infants have access to many of the things that are supposed to be mandated and happening, but when they leave the hospital, they often don't. Consider social determinants of health, promote clinical community partnerships, because we have to embrace community if we're going to actually make some kind of movement on this infant mortality disparities, and then promote a culture of equity. I'd like to end by just thanking again the research team and the funding by NIH for this work. And now I'm very pleased to be able to introduce Dr. Jeffrey Horbar. He is a neonatologist, professor at the Larner College of Medicine at the University of Vermont. He is president and CEO of Vermont Oxford, a collaboration of newborn care teams around the world dedicated to improving quality, safety, and equity of medical care for newborn infants and their families. And he is currently leading his organization down a path anchored in equity. It gives me a great pleasure to introduce him. So I'll turn it over to Dr. Horbar, and I will also stop sharing my screen.
For some reason, Liz, it's not allowing me to share.
If anyone else is sharing, they need to stop sharing to allow Dr. Horbar to share.
And Michael, perhaps you could, I did stop sharing, so if you could give us some clues about how we could help Dr. Horbar be able to share his screen.
If that doesn't work, Dr. Horbar, I believe we have backup slides that the staff can actually project for you, and you would have to just indicate next slide.
Okay. I don't know why it's not letting me do it. It's saying open system preferences. I apologize very much for
not a problem, not a problem.
glitch.
So if we could go to the backup slides, the slides that you shared with us, and you will just have to indicate, next slide.
Okay. Well, it's really a great pleasure to have this opportunity to speak with you today. And I'd like to thank the New York Academy of Medicine, Dr. Laroque Arena, and Dr. Howell for giving me this opportunity. What I'd like to do in the next few minutes is tell you about the Vermont Oxford Network and what we've learned about the care and outcomes for very low birth weight and very preterm infants. And I'd also like to introduce the idea that we call follow through. The idea that it has to be our responsibility to, for patients and families, that this responsibility must begin before delivery and extend throughout infancy, childhood, and beyond, if we're going to have the kind of impact on the long-term health and well-being of infants and families that we really want to have. Next slide, please. The vision of the Vermont Oxford Network is to ensure that every newborn and family achieves their fullest potential. To achieve this vision and realize it, and also to address the shameful disparities that are the focus of today's meeting, it really will require all of us as health professionals to broaden our understanding of our roles and responsibilities, to recognize that we need to think beyond the technical care that we provide to infants and families in the NICU and address the social determinants of health that are what will really ultimately determine their long-term health and well-being. We must learn to practice social as well as technical medicine. Next slide, please. The Vermont Oxford Network now includes over 1,400 teams from newborn units in 34 countries around the world, and we're dedicated to improving the quality, safety, and equity of newborn infants and their families through an integrated program of standardized data collection and reporting, quality improvement, and research. Next slide, please. Our members have the option of participating in either our very low birth weight database, where they submit data on just their very low birth weight infants, or on all of their NICU infants. And as you can see from this slide, the participation in our databases has grown quite substantially since over the 30 years that we've been operating the database. And now about half of the hospitals submit data on all their NICU infants, not just very low birth weight infants. When we aggregate the data in these databases, we see that 97% of all infants 400 to 1,499 grams born each year, admitted to NICUs each year in the US are enrolled in this database. That means we have a unique and valuable resource that teams can use to benchmark their performance relative to their peers, to identify opportunities for improvement, to track their performance over time, and of course, a resource for research. Next slide, please. We also support a number of quality improvement collaboratives that we call NICU and iNICU. And since we started these in 1995, over 700 multidisciplinary teams have participated in these collaboratives, identifying potentially better practices and testing and implementing them using the PDSA Plan, Do, Study, Act model for improvement. We call the practices that we test in these collaboratives potentially better rather than better or best, to indicate that no practice is really better or best until it's been proven to work in your own local environment. One important characteristic of the teams in our quality improvement collaboratives, in addition to them being multidisciplinary, is that we expect all of the teams to include parents as working team members, and we include parents as paid faculty members in all of our collaboratives. Next slide, please. And there has been improvement. This slide shows the rates of late onset infection, hospital-acquired infections occurring after 3 days of birth in infants admitted to 854 US NICUs. And it shows the data from 2005 to 2019, showing the distribution of the rates at the NICUs participating in the Vermont Oxford Network. As you can see from the red line, which represents the median rate, that was over 20% in 2005 and has come down to under 10% in 2019. The dotted and dashed lines represent the 10th, 25th, 75th, and 90th percentiles of NICU rates. And as you can see, if you look back to 2005, 10% of units had rates as low or lower than about 12%. And another 10% of units at the top of the graph had rates of 30% or more. Very dramatic variation. Over time, the median rate has come down and the difference between the top and lowest percentiles has decreased. Next slide, please. This slide shows similar data with the infection data I just showed you in the upper right panel. and information on death, chronic lung disease, necrotizing enterocolitis, severe intraventricular hemorrhage, and severe retinopathy of prematurity, other major mortality and morbidity measures for NICU infants. And as you can see, just as we saw for infection, the rates for all of these serious morbidities have decreased over the 15-year period, except for chronic lung disease. Next slide, please. Having data on the distribution at a large number of NICUs like this allowed us to ask an interesting and innovative question. And that question was, what percentage of NICUs in 2019 have learned to achieve the best decile rates from 2005? Or in other words, how many units now can achieve rates as low or lower than the best units were able to achieve only 15 years earlier? Next slide, please. I find the results quite remarkable. If we look at death and infection, all of the units, 100% of units in 2019 are now achieving rates of death or infection as low or lower than the best 10% of units achieved only 15 years earlier. For necrotizing enterocolitis, severe intraventricular hemorrhage, and severe retinopathy of prematurity, 2/3 to 3/4 of units today are achieving rates that were only achievable by the best 10% of units only 15 years earlier. Only for chronic lung disease don't we see any improvement in this measure. Next slide, please. This figure shows the trend for infection that I showed earlier, but this time stratified by race and ethnicity, with Black infants shown in red, Hispanic infants in green, and non-Hispanic white infants in blue. And what you can see is that although for all three racial ethnic groupings, there has been substantial improvement over this time period, there is a gap. The gap was a little bit larger in 2005 than it is today, but there still is a gap, as Dr. Howell reported in her data. Black infants and Hispanic infants have higher infection rates than white infants. Next slide, please. I won't go into any detail on this slide because Dr. Howell just presented her such important work in much more detail just before I spoke. But just to recap, they found that 40% of the Black-white disparity and 30% of the Hispanic-white disparity at 39 New York City hospitals in morbidity and mortality could be explained by the quality of the hospital at which the infant received care. White infants were overrepresented at high-quality hospitals, and Black infants significantly underrepresented at those high-quality hospitals. Next slide, please. This led us to ask whether there's something special about New York City or whether this finding would actually hold up across the entire United States, and in fact, it does. We divided the NICUs in the Vermont-Oxford network into 5 categories, from those with very low quality on the left to those with very high quality on the right, where quality was assessed using the baby monitor, a composite score of NICU quality. As you can see, focusing on the lower part of the bars, the red part, which indicates the percentage of Black infants, you can see that they represent a high proportion of cases at very low quality hospitals and a much lower proportion of cases at very high quality hospitals, similar to what Dr. Howell and her team found in New York City. After adjusting for region, we didn't see significant differences in the percentages for Hispanic infants, but we did see that Asian infants tended to be concentrated at higher quality NICUs. Next slide, please. So how do we explain and address these disparities in both quality of care and outcomes? And as I said in my introduction, For us, the approach is something that we call follow through. We need to start to understand that our responsibility to NICU infants and their families extends beyond the NICU walls, beyond the hospital walls, to addressing the social determinants of health that ultimately will determine the health and well-being of infants and families. We know that there are shocking and horrific history in our country of racism and segregation, and that this has led to significant inequalities in wealth and income and opportunity in housing, education, and employment that underlie the disparities that we're seeing in healthcare. So there's no way around it. We need to address these. And that's why the Vermont Oxford Network is promoting the idea of follow through in all of our quality improvement work and encouraging us to learn together to practice social, not just technical medicine. Next slide, please. My colleagues, Erica Edwards, Yolanda Obalu, and I recently published an article in Pediatrics that included 71 potentially better practices for follow-through. These practices ranged across a wide spectrum, from promoting a culture of equity all the way to advocating for social justice. Dr. Howell showed a few of these in both of her previous talks, and I encourage all of you to look over the list in this publication, because I think there are many things in this list that are practical, that either individuals or teams could start doing right away to follow through and practice social and not just technical medicine. Next slide, please. I'll give you just a few examples. In the category of identifying, preventing, and mitigating social risks, something clearly we need to screen for social risk and make sure that our hospitals and teams have the resources and personnel to address and mitigate those. But a novel strategy that some hospitals are now beginning to implement is including paralegals or attorneys as working members of their teams, not just referring patients and families to legal aid, but actually having lawyers there on site as working members of the team to address some of the drivers of social disparities: income and insurance, housing and eviction, legal status and immigration, etc. I think this is a very important, potentially better practice, and I would urge those of you who haven't yet considered it to think about implementing medical legal partnerships in your own hospitals. Next slide, please. I mentioned that all of our quality improvement programs now stress follow through. We've developed a framework, which I show on this slide, which our teams use. And I just highlighted for you that one of the key drivers that we're focusing on is equity. We heard earlier that there can't be quality without equity. And I think this is absolutely a cornerstone of the belief that we have in the way we run our quality improvement programs. And I'll try to say a little bit more about this during the panel discussion. Next slide, please. I'm also very pleased to announce today, for the first time publicly, that in addition to our focus on equity in our quality improvement projects and programs, Vermont Oxford Network is now offering a set of innovation grants to promote health equity that we're calling Take Action to Follow Through. This is a competitive offering of grants that we hope will jumpstart follow through activities at NICUs around the United States that are participating in the Vermont Oxford Network Quality Improvement Collaboratives, and that those teams will then share their learning with the wider community, and that through this mechanism, we'll be able to begin to spread an attention to the social determinants of health as a core function of neonatal quality improvement teams. Next slide, please. So I hope that all of us will join together in accepting our responsibility to follow through so that we can realize our shared vision that every newborn infant and family can achieve their fullest potential. Thank you.
Thank you very much, Dr. Horbar, for that presentation, for the work that you do, and that exciting announcement about the grants, the announcement for the grants to promote health equity, and that NICUs around the country folks can apply for. I think that's very exciting. Next, I'm going to introduce the moderator for our next panel, which is entitled Next Steps for Health Equity and Neonatal Morbidity and Mortality. Our moderator is Dr. Deborah Campbell, who is a professor of clinical pediatrics and associate professor of clinical obstetrics and gynecology and women's health at Albert Einstein College of Medicine. Her research interests include regionalization of perinatal care, health services delivery, and psychosocial support interventions for mothers of premature babies. She's a member of the Academic Pediatric Society and a fellow of the American Academy of Pediatrics. Dr. Campbell.
Thank you so much for that kind introduction, and thanks to Dr. Horbar for a wonderful overview of some of the work done by the Vermont-Oxford Network, who really has been seminal over the past 4 decades in the work that's been done. We have 3 presenters who are going to share their perspectives over the next 40 minutes or so. And we'll begin again with Dr. Horbar. We're going to ask each of our presenters to reflect a little on their role and journey in improving neonatal morbidity and mortality, as well as providing some examples of how to improve equity. Since Dr. Horbar actually provided us with a nice overview and framework of some of the current work of the Vermont-Oxford Network, there are actually 2 questions that have already been chatted in that I think Dr. Horbar can maybe in his comments now integrate some response to before we move on to our other presenters. So there was a comment about that it's well documented in the medical literature that Black babies in the NICU do better with Black doctors. The argument that better versus lesser quality hospital may be in question as to poor health outcomes for Black babies in the NICU. Could you please address those comparisons? And then another participant commented that follow through is such a beautiful idea and we are all eager to begin this work. So could you speak to how this work is funded in places when it is successful? Is it the staffing, time funded through charitable organizations, NIH grants? Are there billing paradigms that help to cover this, other modalities? So Dr. Horbar, thank you.
Thank you for that kind introduction, and thank you for those excellent questions. Let me start with the Black doctors, Black babies. I know there was just a recent article, I think it was in the New York Times just the other day, making the case that that's true in obstetrics. I don't know that we have good data in the NICU. I'm not aware of it. I think it makes sense. It's important. It's an area that we definitely need to address, but I'm not aware of specific data about the NICU. The other thing about the NICU that might make it difficult is NICU is a team sport, and the care teams will probably include quite a few different physicians. So it'll be an interesting question. I think it's a very important one. I don't have any specific data to add, though, to the questioner's concern. In terms of funding for follow-through, this is always the first question. You know, it was always the first question with quality improvement. We're not paid to do quality improvement. We have to do it in our spare time. And I think we've evolved from that to hospitals recognizing that quality improvement is an investment that has to be funded with people and time. And I think the same is going to become true of follow through and addressing the social determinants of health. As I pointed out in my talk, we've made such dramatic progress over the past decade or decade and a half in the short-term clinical outcomes for babies. But we now recognize that the shocking disparities that we're seeing are going to require a new approach. And that approach, I think, is follow through in addressing the social determinants of health. And we're going to have to all commit ourselves to this and get our organizations to commit themselves to it. Because I think if we continue to just focus on clinical outcomes, my belief is we're kind of tinkering around the edges. The new area for improvement is addressing the social determinants of health. One of the reasons that we decided to offer these innovation grants was this very issue of funding, to try to spur some initial activity in this area that can demonstrate the success among early adopters, so that other hospitals will eventually come along and recognize that this isn't a luxury. This is the new frontier of what we need to do if we're going to be providing high quality care. Again, going back to what Dr. Bryant said, there can't be quality without equity.
Thank you so much, Dr. Horbar. Why don't we move to our other two panelists, and then we can circle back as we have some more questions chatted in, unless there were other comments that you wanted to make specifically now related to other thoughts about improving equity or your personal journey through your role at Vaughan and also in your work at the University of Vermont.
The only other comment I was going to make was something that, again, picks up on what Dr. Bryant and Dr. Scott had said. We can't have quality without equity, but we can't have equity without representation of those people who are most affected by inequity. Vermont Oxford Network, as I mentioned, requires that all of our quality improvement teams include parents as working team members. But I have to admit that we haven't been as successful in recruiting and maintaining parent team members who are truly representative of the diverse communities that we serve. So I think a major initiative and action that we have to take if our quality improvement work is going to support equity is to recruit families, diverse families, to actually be working team members. And I think there are many challenges to doing this. One of them, I think, is funding, as someone else raised. And I would challenge hospitals to create paid parent advisor positions with the goal of recruiting minority parents as active team members. We do have many hospitals that do have paid parent positions, but not enough. And I think that would be one way forward to start to make real the idea that we need to have a diverse group of parents working with us closely day to day to improve quality.
Okay, thank you very much for that. Now would like to turn over the podium to Dr. Teresa Janovic, who is a perinatal epidemiologist and assistant professor of obstetrics and gynecology and reproductive science and of population health science and policy at the Icahn School of Medicine at Mount Sinai. Dr. Janovic, would you share with us your role and journey in improving neonatal mortality and morbidity, and also your thoughts on how to improve equity?
Thank you, Dr. Campbell. It's an honor and pleasure to participate today. I'm going to share my screen. I have a few slides to share. So I'm going to share a few thoughts about next steps toward anti-racism research to achieve neonatal health equity. And to do so, I'm going to share some new findings based on work with Dr. Howell and her team on racial and economic segregation and very preterm birth neonatal morbidity and mortality. And this work is really the culmination of a lot of thought and discussion over the past 5 years that I've had the pleasure of working with Dr. Howell and her team on this research. And to do so, I'm going to situate these new findings in an anti-racism research framework called Public Health Critical Race Practice. And just as a brief disclaimer, I really should call this not next steps, but baby steps, as the work I'm going to present is a bit retrofitted to this framework and honestly just scratches the surface of the power of such an approach. So for those of you who aren't familiar with the praxis, the Public Health Critical Race Praxis is developed by Chandra Ford and colleagues, and it's a practical application of critical race theory for population health researchers and big data folks like myself. And the aim is to move beyond merely documenting health inequities toward understanding and challenging the power hierarchies that undergird them. And the praxis is really a roadmap for researchers to follow. And there's 4 main foci. And the first is titled Contemporary Racial Relations. And again, I'm just sort of scratching the surface of this. But one aspect of this focus is the need to define race as a social construct in your work and conceptualize racism, how it operates in your study context. And so this thinking brought us to question, as probably many people who saw our results looking at differences in hospital quality and very preterm birth, neonatal morbidity and mortality, and the disproportionate Black and Latino infants in those hospitals. Well, what are the structural determinants that underlie these hospital differences? What is really undergirding these differences we see by hospital? The second focus is to challenge knowledge production. And this is to take a critical view of current research and practice. And so one example of this was as we moved to incorporate zip code or neighborhood measures in our analyses, we looked at previous research, or much previous research on hospital quality that just includes zip code, poverty, or even proportion Black residents as a proxy for patient factors, and really meant to explain away potential differences in hospitals and quality, and attributing it really as an individual patient factor as opposed to studying it as an underlying structural determinant or structural racism. The third focus is a critical assessment of concepts and measures and how you operationalize them in your research. So this caused reflection on what type of segregation measure to use. And also, it brought us to think about, well, what about the hospital neighborhoods? We were initially interested in, and many people asked about this research in terms of, well, what neighborhood are the women from? And we also were thinking, well, what about what neighborhood, where the hospital is situated? And to sort of better define our concepts of the underlying structural determinants and structural racism of our findings. And finally, the last focus is action, to use knowledge produced by your big data research for action. And you are all a part of that today. So Dr. Howell mentioned earlier the history of redlining in New York City and how Nancy Krieger and co-authors had found that neighborhoods that were considered hazardous, the red neighborhoods in this map, were associated with a current day increased risk of preterm birth. So I'm just reminding you of that map when I'm showing you present day racial economic segregation. And what you're looking at here is a measure called Index of Concentration at the Extremes. And basically what this is showing is that the red neighborhoods have high relative concentration of poor Black households, and the blue neighborhoods have high relative concentration of wealthy white households. And researchers from the Department of Health have shown that these neighborhoods, the red neighborhoods, the high concentration poor Black neighborhoods, have 2 times the risk of preterm birth and 4 times the risk of infant mortality compared to the wealthiest white neighborhoods. So what does this mean after you're born and you're in the NICU? Well, we extended the investigation a bit further. So given that infants were born very preterm, how much additional risk do those whose mothers reside in neighborhoods with high concentration poor Black households have compared to those from neighborhood, primarily wealthy white neighborhoods? And we found that even conditioned on being born very preterm, there was still 1.6 times the risk of mortality or severe neonatal morbidity. And then the next question was, how does this actually drive hospital inequities in neonatal morbidity and mortality by looking at hospital delivery as an explanatory factor for these findings? And we found that after adjusting away for both mom and baby patient factors, the hospital where the infant was delivered explained 2/3 of this difference in risk between neighborhoods. And then, as I mentioned, the next question was, well, what about the neighborhood of the hospital? And what you're looking at here is the joint effect of the mom's neighborhood and the hospital.
Dr. Janovic, I think you froze. Can someone help Dr. Janovic?
If we pause for a second, she may regain it. If the internet is unstable, there's nothing to do except to wait. She may need to reconnect.
That is correct. Please give a few seconds.
In an effort thinking about moving forward, perhaps Dr. Campbell, we can continue with the next person, and then we will allow Dr. Janovic, if she gets reconnected, to finish her presentation.
Okay, great.
Thank you
so much, Dr.
Exactly.
Howell. So at this point, we'll shift gears, and as Dr. Howell mentioned, we can shift back when Dr. Janovic is available to finish her comments. It's my pleasure to be able to introduce Dr. Adrienne Mercer, who's program director for the New York State funded Maternal Infant Community Health Collaborative at the Northern Manhattan Perinatal Partnership. Dr. Mercer holds a doctorate in health education from Teachers College at Columbia University and is also a certified health education specialist. I think it's really wonderful that we have an opportunity to get some reflections and hear the experience of one of the comprehensive prenatal perinatal networks in New York State that, for those that don't know, was funded or established in 1986 by Governor Mario Cuomo, father of our current governor. And it was an important effort at that time to reduce infant and maternal mortality, as well as developmental disabilities, which certainly as a neonatologist and pediatrician is something core to what we do. So with that, thank you so much, Dr. Mercer, and we look forward to your reflections on your role and journey in improving neonatal morbidity and mortality, and also sharing some examples of how you view improving equity.
Okay. Thank you very much. Thank you very much, and thank you for having me. I guess I would say I'm boots on the ground. We're right there in the community, right there with the consumer on a day-to-day basis, dealing with those social determinants of health that are impacting their health and wellness. NMPP is an organization that's over 25 years old. We are a life course organization. We work with the woman across the lifespan. We use evidence-based and promising practices programs. Like you said, we started a long time ago. We started with a Healthy Start program, which is a national program, which also has a community action network attached to it, which brings together providers and consumers to the table to discuss what's happening within the community and discuss ways that that can be addressed, and making sure that that information gets to those elected officials that impact policy and funding that comes with into that community. So I guess in our journey on improving neonatal mortality and morbidity, I guess it's in line with our mission, which is to help women take charge of their reproductive and economic well-being. And how do we do that, I guess you would say? With our case management programs, they're really intense. They do a screening on a variety of areas of that individual life, and then we develop a service plan with that individual that will help meet that individual's needs. We have a Healthy Families program, which deals with mother-child bonding and reducing child abuse. We have, like I said, the Mitch program, which I'm responsible for, which makes sure women are connected to health insurance, connected to a healthcare provider, that they're receiving the social support services that they need, and that we are also partnering with those organizations that meet their needs. And when we talk about partnerships, yes, I'll share with you, we have a very strong partnership, and it really speaks to what Dr. Howell talked about in the beginning. I'm like, okay, that is spot on. Within the hospitals, things that work is that team approach. We have a partnership right now with New York Presbyterian Hospital, and we have several community health worker programs. And that's not a partnership on paper or a partnership where it's one-sided, but we're coming together on a weekly, bi-weekly basis to discuss the cases that our community health workers are serving. One of our community health worker programs with New York Presbyterian has a doula component attached to it and a community health worker component attached to it for moms who are delivering. Could be first time, second time, it doesn't matter. They are offered a community health worker and a postpartum doula that will be with them for until they get to that postpartum visits, because we know that at NYP, the postpartum visit rate was really low, and we want to make sure that new mom got back to that visit within 2 to 6 weeks of delivery. So we offer them that doula care. And that's that I guess I'll use our client's words. One of our consumers, she shared her experience of the doula program. She wanted us to know how it impacted her life and helped her. She wrote an email to the coordinator of that project. She said, "Hi, Faja. Hope you're doing well. Sharonda gave me your number so I could share my experience with the doula program, New York Presbyterian and NMPP doula program. Having my baby at NYP Hospital was a great experience. I appreciate being part of this doula program. Having a person I can talk to made me feel supported and that I matter. Sharonda was also friendly and available to answer questions I had, even if it was not during our weekly session. Sometimes we need a person other than a family member or a doctor to provide emotional support and guidance on how to take care of our babies. And for me, that was Sharonda. She talked to me about tummy time for the baby, cards to enhance her sights, how to start a sleep routine for my baby, massages that will help reduce gas, and many other tips. This is one of the reasons why I like NYP Presbyterian. They care about their patients. I hope this program can be provided to all first-time moms. And another thing that I think that being on the ground helps us to see firsthand after mom leaves the hospital is what's happening in that home environment. And two things that I think that are very important, especially when we talk about neonatal mortality and morbidity, is nutrition and safe sleep. We are seeing an increased number of moms who have to go back to the emergency room after they bring their baby home because that baby is not thriving, because they're not able to take the approved formula that they're using. So they wind up back in the hospital for dehydration. Moms are finding that there is a formula that babies can take, but that formula is not approved, and it's expensive. So we have to try to navigate that issue. How can we get this explain to the doctor what the issue is? Can this be prescribed? What are other resources in the community to get that mom what she needs? Also, when it comes to safe sleep, we have quite a few moms who are residing in shelters, so the space isn't quite that large for them to have a crib sometimes, or they may be living in a situation that's shared, so there's no room for a crib, or they don't have the resources for that crib. So we have to make sure that they have that safe sleep environment, and talk to them about back to sleep and the importance of not sleeping in a bed with that baby. So those are two issues that we target right as soon as we get home. As soon as the mom gets home, or even before she gets home, we begin to talk about those particular areas. So that's kind of it in a nutshell.
Okay, thank you so much for sharing that, Dr. Mercer. We have Dr. Janovic back, so perhaps we can move back to her presentation, allow her to finish her comments, and then we can move on to the responding to the comments and questions in the chat. Dr. Janovic.
Great, thanks. Sorry about that technical problem. So I guess I was really just about to conclude and show these findings that that stimulate kind of next steps in research involving structural racism around not only residential segregation, but also what hospitals experience in their neighborhoods. And what you're looking at are findings that show on the left, the 38%, as that's the neonatal morbidity and mortality rate among infants to mothers who reside in high concentration Black neighborhoods, if the infants are delivered in a similar high concentration Black neighborhood, whereas infants to moms from similar Black neighborhoods who are delivered in hospitals that are located in wealthy white neighborhoods have a lower risk of neonatal morbidity and mortality. And these findings kind of stimulate some next steps in research and really thinking about structural racism, neighborhood context, and hospital quality. And so what are some of the mechanisms by which where a hospital is located could influence quality? And just some in the literature that there might be some evidence for include fewer resources, burnout, staffing, overwork, and some of these things that came up in the qualitative results that Dr. Howell presented a little bit ago. And next, how can hospitals bridge the gap between the NICU and the neighborhood? And we heard a little bit more about that from Dr. Horbar as well. And then finally, I'm thinking a bigger picture, what type of policies, housing, including housing, health, and other intersectoral policies, how might they dismantle the structural racism that's undergirding the patterns we find in the body of research presented today? So there's a need to investigate what current policies have and how they currently impact neonatal health, but then also what new ones we need as well. So thank you again.
Okay, thank you so much, Dr. Janovic. We do have a number of comments and questions that have been added in the chat room since we began this session. One issue or one comment just to readdress a bit relates to having physicians of color caring for patients of color. In particular, the specific comment related to Black physicians present to be able to take care of Black patients. I think that certainly addressing workforce issues, going back to certainly medical school and increasing diversity in the medical school classes is critical. But even as one tackles and works to admit more diverse classes, we need to, I think, also recognize that every student brings their own series of experiences. And just because one has a Black physician does not necessarily mean that that person's going to understand where the patient's coming from and what the challenges are for the patient. So I think it also speaks to the importance of everybody learning to really listen with non-judgment, with an open mind, to try to learn each patient's story and go from there. But I think it is an important issue that we need to not just focus on diversity in the workforce for the other members of the healthcare team, but also really put some thought and real work into increasing diversity among the medical professionals, particularly physicians, caring for families within our communities. There was a comment from a neonatologist who's a participant who commented that she actually, when she's on service, she sees all the babies on her service, but does make specific effort to try to see the babies of color while she's on service. I'm assuming that she also tries to connect with families again to try to offer that particular support. And there was a question about environmental factors such as air quality and access to nutritious foods. I think both Dr. Horbar and Dr. Janovic provided some reflection, some comments about, as part of the social determinants of health, sort of the community factors, the neighborhood factors that certainly impact health well-being and contribute to outcomes. So whether any of our speakers would like to be able to reflect on that further. Dr. Janovic, maybe you could start, and then we could see if Dr. Horbar or Dr. Mercer.
Sure. Yeah, I think that we need to think outside the box in terms of interventions that address social determinants as well as the physical environment. But the question mentioned air pollution. So, for example, I've seen a recent intervention about air filters in the home and providing them free of charge, and does that improve respiratory health of infants? Now, would that be the case in improving the home environment of a very preterm infant? So that's just an example of kind of thinking outside of the box in terms of how to address, how to bridge the gap when Dr. Horber's point about following through between the NICU and the home as well as the neighborhood.
Dr. Horbar, do you have any additional to share?
Just a quick comment that I think hospitals and academic medical centers and health systems are going to need to accept responsibility for the neighborhoods within which they reside. That could take many different forms, and I think there are a number of children's hospitals already that have started to recognize that they have a responsibility for their communities. This is not, it isn't taught in medical school, but I think it's going to be the new way, and it has to be.
Dr. Mercer, do you have anything that you would like to add?
Yes, I guess as a grassroots community-based organization that is part of our task to make sure that our clients know what resources are in the community for them, where food pantries, what are the days those food pantries are working. And again, those partnership building is very important. We partner with the Common Pantry, and for years they've done workshops on an ongoing basis for our clients on how to prepare healthy meals. They also provide the clients with the health bucks, and we don't just give them health bucks. We take a trip to the farmers market to do some education there about choosing healthy choices. So that's part of our role. Yeah.
Okay, thank you. There was a comment, as well as a question related to paid maternity leave, and then also some interest in the technical assistance for needy families, income assistance type programs. And maybe to start first with Dr. Horbar, from across the national level, since certainly Vaughn works across all 50 states, in terms of how Vaughn has thought about working with states and the different entities that really support families, and how to integrate that in, and how that could be translated down to the local level. And then I'll also ask Dr. Janovic and Dr. Mercer to share their thoughts about that as well.
Yeah, over the history of Vermont Oxford Network, our membership was initially individual NICUs. Then it moved more recently to health systems, and I think states and groups like that. We haven't yet made any major programs in that area that I would try to tout on today's call, but recognizing the importance of that, certainly.
Okay, thank you. Dr. Mercer, your thoughts?
I guess when it comes to economic stability, we have to be realistic. A large percent of our population, they are undocumented. So sometimes it's really limited of what it is that we can do, because a lot of them are working off the books, or, and for those who maybe are documented, we try to link them into programs that might help them build some economic stability. But again, like I said before, it's about partnering with other organizations that have that expertise. Like we are a member of the New York Immigration Coalition, and a wealth of information and other partners that we can tap into to meet those clients' needs, because we can't be everything to everybody. But that's the major thing, partnering with organizations that can, meet those needs. And we do that assessment, and we really sit down and talk with clients about what it is that they want and where they're currently at. And if we're able to link them to that program, or maybe sometimes we'll have someone come in to talk about job development skills, like we have a fatherhood component, because you can't just talk about the mom without talking about the dad. That is a very important component to it, and he's usually that provider. So we try to bring him into this mix and say, what is it that you specifically need, and try to link him to those services. So we look at the family as a whole.
Okay, thank you very much. Dr. Janovic, anything that you'd like to share as well?
Sure, I'd just like to mention, policy, that it might be an opportune time in the coming months for several areas of policy that could have potential for large impact on the issues we're discussing. And one of those is paid family leave. There is apparently the new administration will push federal paid family leave legislation, and paid family leave there is some evidence that it improves infant health by reducing hospitalizations. But certainly when we're thinking about parenting in the NICU, access to paid family leave is crucial. And I would just mention that, as paid family leave policy also has to be there has to be an equity lens in implementing and evaluating it to ensure that all parents have access to it. And then the second area is with access to Medicaid. And as Dr. Mercer mentioned, important to a lot of families in New York City, but also nationally, are the fact that many are not eligible for, many parents are not eligible for health care for themselves due to their undocumented status. And there are initiatives at New York State legislature to try to cover all persons regardless of status. But also there'll be national initiatives to try to remove the 5-year waiting period that even legal residents have to wait in a lot of states to be eligible for Medicaid. So I think both of those are just some areas that we can advocate for that should have impact on what we're discussing today.
Okay, thank you, Dr. Janovic. There were a couple of comments that I think raise an important issue that maybe we can spend a few minutes discussing. And one of the participants wrote in that there have been prior multidisciplinary initiatives with OB, neonatology, psychiatry, psychology to improve access to maternal mental health in the antenatal period, or alternatively, a focus postnatally with parent-centered collaboration with high-risk mothers while their babies are in the NICU. And just thoughts about how we can improve access to maternal mental health or supportive health for families whose babies do require neonatal intensive care. And then before commenting on that, there was another participant who chatted in that she keeps hearing about the social determinants of health, but has not heard mention of social workers and mental health clinicians in terms of how they can support the processes of care in our families, and how the three of you think about their role in this work. So maybe we could spend a few minutes talking about that, and Dr. Janovic, and then Dr. Mercer, and finally Dr. Horbar. Dr. Janovic.
Sure, absolutely. I guess just to briefly, regarding mental health and health overall for the mom while their infants in the NICU, I guess I would just mention again the issue of postpartum health insurance and the importance to extend Medicaid eligibility beyond the 6-week cut point. And there's a lot of legislative action around that at the moment. And then the second point would be in regard to multidisciplinary teams. I think Dr. Horbar did speak and probably can more too about like the nature of NICU teams, but I guess I would also give a shout out to public health that I think in the discussions about diversifying the medical workforce, I think we also need to think about the public health workforce and sort of a broader range of, especially if we're interested in addressing social determinants of health, to broaden the contribution and the sort of a collaboration between the medical community and the public health community.
Thank you. Dr. Mercer?
Yes, I agree with definitely what she just said, especially around Medicaid reimbursement. One thing that I found is that the mental health is the need is increasing, especially with COVID and the pandemic. It's even greater, and it's a greater with our adolescent moms also. One issue that I've seen with our clients is within the hospital system, sometimes those that are working in the hospital system are not quite clear on the rules, the policies. We had a client who almost lost her mental health services because that person at the front desk thought she did not have health insurance when she actually did have health insurance. And if we weren't able to go a little bit higher up into the administrative level, she would not have had that care. So sometimes I think within the system, everybody's not on the same page and everybody doesn't know what's going on. And sometimes they just need to spend a little bit more time with that frontline staff at the front desk, because that's the person who can really get you in or get you out of care. We do, in our partnership with the hospital, we are working with the Family Peace Center, and they come in and they provide screening for our moms. They do an ACE screening. And if mom is interested in further services, then the provider will then enroll her into their program. But one thing I would recommend is that hospitals use those services that are in the community. There are home visiting programs in all of the boroughs, and they can relieve some of the weight that you have on meeting all of those needs, because you can't be everything to everybody. We can deal with those social determinants of health, and then we can give you that feedback and say, this is what the client is saying. How can we work together to make sure that the service that she's getting is comprehensive?
Okay, thank you, Dr. Mercer. We're limited in time since this session is just about done, but I think that there were two questions or comments that have been chatted in a few times, asking about nurse-family partnership, and I think that ties in very much with what you were just reflecting on, Dr. Mercer. And then also the issue of being able to provide supports and resources to family without having to necessarily over-report. And I think that all of us have struggled with that, because many of the resources and supports out there oftentimes require that we go through Child Protective Services or somehow engage with Child Protective Services, and that often for family, Black and brown families in particular, ends up with more than just access to supports, but a referral, an investigation, and sometimes actual interventions that are negative in terms of supporting the family construct. So perhaps if you could comment on that, and then Dr. Janovic, and then we could have Dr. Horbar just quickly give us his higher level reflection on that.
Okay. Well, we have the Healthy Families America program, and in that Healthy Families program, they deal with those issues of parent-child bonding and discipline, and and they're in the home on a weekly basis to work with mom. And we don't come in with the idea, oh, if you don't do XYZ, I'm going to call child welfare on you, because you could get hurt, and two, and we've had some incidences where clients are really like not trusting, and it's like, who are you? And if I'm sharing with you that I have a domestic violence issue going on, and the next word that comes out of your mouth is child welfare, then I'm going to run from you. So it's really important that you have the right trained staff on board, that you have that licensed social worker on board that can intervene when you have some of those issues, and that you're letting mom know that we are here for you. We're not here to tell you how to live. We're here to give you the tools that you need. But we do, in certain instances, have to let them know we are mandated reporters. And if we think that there's a risk to the child's life, and if you think that there's a risk of the child's life, you're mandated to, take the next step.
Okay, thank you. Dr. Janovic, about 30 to 45 seconds for your thoughts, and then to Dr. Horbar. We have a minute.
Sure, I don't have much to add. That was really moving. So I don't really have anything to add. We can go on to Dr. Horbar.
Okay, Dr. Horbar, you get the last word.
Yeah, I agree with everything that has been said, and the wisdom that we hear from Dr. Mercer is inspiring. I think the issue that I would just come back to is the community clinical partnerships and how important those are going to be in allowing us to follow through. We can't possibly have everybody we want on the NICU team, and partnering with our communities and the strong resources that they have is going to be critical. We had a wonderful example of this on a recent quality improvement session where the Navajo Nation has a program of fruit and vegetable prescriptions that is done in concert with the community and makes a huge difference for families. I think that's just one example of the types of community partnerships that I think Dr. Mercer has such terrific experience with.
Okay, thank you so much. And we could certainly speak for a lot longer, but we do need to move on to our next reflective section. So thank you on behalf of all of us to Drs. Horbar, Janovic, and Mercer. Dr. Howell or Dr. LaRocque?
Yes. Yeah, thank you. Thank you so much. So first of all, I want to thank the participants for actively putting their questions on chat and Q&A. I do want to give you some feedback that a great number of you participated in the first reflective session. I believe it was, I said 169 participants. It may be more. So I really encourage you, first of all, take a deep breath. The conversations we are having are difficult ones, but I want you to focus on that equity lens and really what are the bold actions that we can go through to be able to make a difference. Your conversations here reflected an increasing focus on policy. Just very brief summary, Dr. Hobart mentioned the need, since Vermont Oxford does not stratify by race and ethnicity, that we have limitations in understanding the problem, but we need to go way beyond this to prevention and looking at disparity boards and in true partnership with communities and not ignoring the poverty that surrounds many academic centers. So given that, I want to thank you. I want to remind you of the maternal health equity hashtag. I also want you, and I should have from Joey Harper, please, would you kindly put the slide up again? That is going to display the link that you either cut and paste or click in the chat that will allow you to share your thoughts and respond to 3 questions posted. This is really critically important because following the summit, we are going to continue this work to take a look at policy and research to policy to practice implications of the work that's being presented to you, but also your thoughts. I want to remind you that your responses are voluntary and anonymous, and the NIAM IRB has reviewed and approved this survey research, and we hope it will lead to an action agenda. We will reconvene at 12:17, so in exactly 10 minutes, we will reconvene. So take a deep breath, stand up, reflect, and share your thoughts. Thank you.
Somebody was also asking about how to turn on closed captioning. I don't know whether somebody can help with that.
I would defer to either Joey Harper or Michael Confora, Laura Pronovost, if you could answer that question.
Yes, unfortunately, due to the live nature of the program, we don't have the ability to broadcast with closed captions.
So please go on to the link and to answer the questions, and we hope to exceed responses. I hope we currently have 350 participants. I would hope to get every single one of you to comment and to share your thoughts with us. Thank you.
So welcome back, everyone, for the third session of our summit today. I'm very pleased to be introducing to you Dr. Jennifer Zeitlin. She is a perinatal epidemiologist and a tenured research director at the Obstetrical, Perinatal, and Pediatric Epidemiology Research Team at INSERM in France. She's also an adjunct professor at the Icahn School of Medicine at Mount Sinai. Dr. Zeitlin's research focuses on assessing the impact of organization and quality of care on the health and development of babies born very preterm using multinational prospective cohort studies. She leads several efforts in Europe on looking at research both for the very preterm infant as well as preterm births. I'm particularly pleased that she has joined us from overseas today to share a local and global perspective on the maternal infant dyad and its implications for maternal and child health equity. Thank you, Dr. Zeitlin.
Thank you, Liz, for that introduction. I'm going to share my screen. I'm really honored to be part of this summit and take part with all the inspiring speeches and commentary, and I'm excited to present our results on the mother-child dyad. Let's get my presentation up. That's the end of it. Oh. I think I can just put it. Hold on, sorry, it's not at the end. Let me just go back to the. Let me get out of this a second. Sorry, I'm having a bit of a technical difficulty and I'm trying to stop this and then I'll do it again from the beginning. Sorry about that. Okay, I'm going to give it another try. I'm sorry, this is taking, it might be the connection with all the people. It's not going into, I'll do one more attempt and then I know you have slides if I can't manage to make this work, but let me try one more time.
If not, I can share my screen for you.
Okay, it's working over here. I might ask you to do that in 1 second. I'm just going to try one more time.
Yeah, no problem.
There we go. And let me just put it in so that it can be full screen. Excuse me for the technical issues. Okay, before I start talking today, I just want to explain a little bit my background, how I came to work with Dr. Howell's team. I had a mid-career fellowship from the European Union in 2010 to come work with the Department of Population Health Science and Policy at Mount Sinai. As Liz said, my own research is on the organization and quality of care for very preterm births, mainly carried out in France and in other European countries. And it has been enormously valuable and enriching for me to explore these questions in a disparities framework in New York City. And at the end of the presentation, I'll provide a few thoughts about these research questions in a comparative US-European context. So as we have heard this morning in the presentations by Dr. Howell, there is a crisis in healthcare quality for mothers and babies of color. These studies have a unique strength because they explore similar research questions in studies with similar methods and using the same data source. And so this allows us not only to compare and discuss results in parallel, but also to explore these questions for mother and babies together. Now, to the non-researchers listening to this presentation, studying the mother and baby together may seem self-evident, but research on high-risk babies and severe pregnancy outcomes among mothers has been done by different research groups using different data sources. And for instance, in this silo representing very preterm birth, mortality and morbidity, the cohorts that I am familiar with in Europe, including my own study of very preterm babies in 11 European countries, do not include data on maternal outcomes during delivery, including maternal death, ICU admission, and other maternal postpartum outcomes. The mother-infant dyad concepts, in contrast, focuses research on the mother-child unit of analysis. It emphasizes this physiological and psychosocial interaction between the mother and the infant. It has mainly been applied in studies on bonding and feeding, and rarely in studies of perinatal quality improvement. However, it's highly relevant to quality and disparities. One, because poor maternal and infant health outcomes and disparities in outcomes result from shared pathways. Further, it reflects the goals of pregnant women, families, and clinicians to have both the mother and child be in good health. And the consequences of disparities in maternal and infant health are interconnected across the life course. Our studies of very preterm babies and also of severe maternal morbidity among mothers meant that we were able to apply the mother-infant dyad to quality concept, to quality and equity. We have conceptualized this in 3 domains, one on individual patient care and outcomes, the second on quality measurement and improvement, and the third in terms of postpartum and long-term health outcomes. I'll be presenting results from studies on the first 2 domains. We have a paper that's currently in press, which includes a discussion of these concepts, including review of the literature. And I'd like to acknowledge the work of the postdoc on this project, Kimberly Glazer, who is first author of this publication. So the first domain concerns patient outcomes. And here we apply the maternal infant dyad to understanding the connections between preventable, quality-based disparities in maternal and newborn care, and use this knowledge to improve individual patient care and delivery outcomes. In this study, we sought to understand the connection between severe maternal morbidity and outcomes of the baby among infants born very preterm before 32 weeks of gestation. We know that severe maternal morbidity affects about 1 to 2% of all deliveries. We also know that it's more frequent in very preterm deliveries. However, no data on the percent of very preterm babies whose mother experiences severe maternal morbid event existed, or whether this affects the child's mortality and morbidity. The methods are the same as those that have been presented in the previous presentations this morning. The data source is vital statistics linked with mother and baby discharge abstracts. And the population is live very preterm infants from 24 to 31 weeks of gestation. We defined severe maternal morbidity as previously based on the CDC algorithm. And the result that I'll present in the results here are infant mortality, so death up to 1 year. In terms of results, we found that over 1 in 10 very preterm infants had a mother who experienced severe maternal morbidity. This was more common among non-Hispanic Black very preterm babies, and other risk factors were older age, multiparity, and pre-existing health conditions. The very preterm 1-year mortality in our sample was 7.7%. Among babies whose mothers did not experience severe maternal morbidity, but it was 11.2% in those who experienced severe maternal morbidity. And here is a graph showing a survival curve. The blue line is infants born to mothers without a severe maternal morbid event, and the red is mothers with severe maternal morbidity, which in an adjusted model gave a 40% greater risk of death for babies whose mothers experienced a severe morbid event. So this means that we show in these results show that severe maternal morbidity is an independent risk factor for very preterm mortality, which means one, it's important to include the deaths that are associated with severe maternal morbidity in the measure of the total health burden of severe maternal health outcomes. Secondly, the management of severe maternal morbidity may consequently be a potential lever for improving very preterm outcomes. And it illustrates the importance of applying the mother-infant dyad research paradigm in terms of understanding quality and disparities. Further questions involve the underlying mechanisms. Is it the poor quality of care that contributes to both the SMM and the very preterm outcomes? Or are there unique health needs that arise when both the woman and the infant experience delivery complications? The second domain in which the concept of the maternal and infant dyad can improve our understanding of quality and equity is quality measurement and improvement. Tracking joint maternal-infant disparities is important for developing effective quality interventions and measuring the full burden of quality gaps on disparities. As we saw this morning, we documented large disparities in risk-standardized hospital performance for severe maternal morbidity and for mortality and morbidity for very preterm infants. But there are unanswered questions. Does hospital-level performance for mothers relate to hospital performance for very preterm babies? And how might this association impact on disparities? These are two figures that you have already seen today. The one on the left is the hospital rankings after adjustment of a risk standardized maternal morbidity, which range from about 1 to 7% across 40 hospitals in New York. And on the right, this is the risk standardized very preterm mortality and morbidity across those same hospitals. So our first question was whether or not these rankings were associated with one another. This is the scatter plot that shows the association of the SMM and very preterm birth rankings. The very preterm rankings are here and the SMM rankings are there. So this shows that there is an association, but that this association is moderate. In other words, there's a higher probability that hospitals ranked poorly on very preterm birth outcomes would also be ranked poorly on SMM, but there are also hospitals that have low very preterm birth ranks that have higher SMM ranks. Our next step was to use statistical analyses to identify groups of hospitals that were similar based on both metrics. So those that were, as you can see at the bottom of the slide, had excellent rankings for both very preterm morbidity and mortality and severe maternal morbidity, going up to those hospitals that were poorly ranked on both dimensions. Now, I'm going to, hold on a second, the camera is getting in the way. I'm going to, this graph shows the predicted probabilities that women will deliver in these 5 different clusters of hospitals after adjusting for their maternal demographic, social, and clinical risk factors. And let me explain. This line shows for Black women, the predicted probability of delivering in a excellent hospital, excellent on both dimensions, is 10%. But Black women had an almost 30% risk of delivering in a hospital that had poor outcomes for both moms and babies. And this, sorry, my screen is stuck. Here we go. So this led to 7 times greater risk of delivering in a hospital with poor outcomes on both dimensions, and 5 times for Hispanic women. So what we found was that hospital performance for maternal and high-risk infant outcomes is only moderately correlated, but the Black and Hispanic women face a double threat. They're more likely to deliver in hospitals with poor maternal outcomes, and their very preterm infants are more likely to be born in hospitals with poor neonatal outcomes. This finding was not explained by differences in insurance coverage, maternal education, or other sociodemographic clinical characteristics. So efforts to integrate and strengthen quality improvement in both obstetric and neonatal care at hospitals where Black and Hispanic women deliver are thus a critical step to reduce the co-occurrence of disparities for maternal and child health outcomes. The third domain in the application of the mother-child dyad to equity and quality is postpartum and long-term health outcomes. Our study focused on delivery outcomes, but it raises many questions about the long-term maternal and child health. Disparities in health and development problems associated with very preterm birth due to quality of care, as we've seen, but they're also due to a higher risk of being born preterm. And we found in our sample that compared to the white infants, Black infants had a 2.7 times higher rate of intraventricular hemorrhage and a 4.4 higher rate of bronchopulmonary dysplasia, while Hispanic infants had approximately 2 times higher rate than white very preterm babies. These are the 2 neonatal morbidities that are most strongly related with future neurodevelopmental impairment. From the mother's perspective, care for mothers experiencing adverse pregnancy outcomes is needed for emotional trauma, prevention in future pregnancies, and the effects on other aspects of maternal physical and mental health. Therefore, a mother-infant dyad concept is central to fully interrupting the intergenerational transmission of health disparities associated with pregnancy and delivery. In my just several slides, I also wanted to talk about the comparison between the US and Europe and how this relates to this question of quality, equity, and the mother-child dyad. So in Europe, there are more comprehensive health insurance, maternity leave, and social support programs. And overall, there are better outcomes in Europe, better pregnancy outcomes in Europe. This is a graph that shows the infant mortality rates this is from the OECD in 2021. The rates are from 2017, with the US having a 5.8 per thousand infant mortality rate. France and Great Britain are there with a 3.9 per thousand in red, and then I put Finland, which has the lowest infant mortality in Europe at 2 per thousand. Similarly, preterm birth rates are much lower in Europe. They range from 5 to about 8, whereas the United States preterm birth rate is about 9.6. This is data from 2015. And I just wanted to say that if the US, for example, had France's birth rate, there would be about 100,000 fewer preterm babies born every year. Similarly, from maternal health indicators, this is the maternal mortality ratio. In the US, the CDC gives a maternal mortality ratio of 17.4 per 100,000 births. And in France, using the same definition, that ratio is 8.1 per 100,000 live births, so more than half. And these data come from the French maternal mortality audit, and their report on 2013 and 2015 just came out last week. It's run by Dr. Deneutrot in our unit in France. So in the US, and as we've heard, and Dr. Howell presented several slides showing this, there's large disparities by racial ethnic group, with non-Hispanic Black women having a maternal mortality rate of 37.3. In France, the report presents information on migrant women by country of birth. And what we can see is that there are also very large disparities, and in particular for women migrants who were born in sub-Saharan Africa, with rates of 21.6 compared to women born in France with ratios of 6.1, and in other countries, migrant women from other countries, which is 22.6. The other result from the French audit is that about 60% of maternal deaths were considered probably or possibly preventable. And in 66% of cases, the care provided was not optimal. This is similar to what audits find in the US in terms of preventability of maternal deaths. So in conclusion, the comparison with Europe emphasizes the common health and social policy determinants of maternal and child health, and the relevance of the mother-infant dyad at the social and policy level as well. It also calls attention to the importance of policy objectives of providing universal health insurance and social support programs and maternity leave, much as we've been discussing in the last section. But an important point is that having these social programs and access to care does not ensure quality of care for everyone, and that quality interventions remain an important tool for obtaining better mother and baby outcomes in all settings. And similarly, having these programs does not ensure equity. Discrimination and disparities exist even in the presence of social programs, and therefore targeted interventions are needed to address these. Thank you.
Thank you, Dr. Zeitlin, for that very important and enlightening discussion. I'd next like to introduce the moderator for our final panel, which is entitled The Mom-Baby Dyad and Implications for Maternal and Child Health Disparities. Our moderator is Dr. Lynn Roberts. Dr. Roberts is the Associate Dean for Student Affairs and Alumni Relations and an Assistant Professor of Community Health and Social Sciences at CUNY Graduate School of Public Health and Health Policy. Dr. Roberts was also a member of the Governor's Task Force for New York State, and she's been a major contributor to efforts in New York City and New York State to reduce disparities in maternal health outcomes. Dr. Roberts.
Thank you, Dr. Howell. And again, as many have said, what a privilege to be a part of this summit and to follow such eloquent speakers. I will be following the format similar to my prior moderators by briefly introducing each of the speakers in turn. You can refer to their more extensive bios that have been provided, and in order. We will be hearing from Dr. Johan Prophet. I hope I've pronounced Dr. Prophet's first name correctly, is the Chief Quality Officer at California Perinatal Quality Care Collaborative and Associate Professor of Pediatrics at Stanford University. The question I'm going to direct to each of you is, I'll first state broadly and then might make it a little more specific or tailor it to each of you. Please describe, Dr. Prophet, current efforts in your organization or at the state level where you are based that highlight novel models of care aimed at improving the health of the mom-baby dyad, specifically for underserved communities. And if you would, given your specific work in NICUs in California and related to quality improvement, what do you believe is the single intervention that has the ability to have the greatest impact on care within a NICU? Dr. Prophet, please.
Thank you, Dr. Roberts and Dr. Howell for the opportunity to be here today among such an illustrious group of researchers and advocates in this very important area. I did bring a few slides. I'll just pull these up. There you go. I hope you can see them. Let me know if you can't. So the California Perinatal Quality Care Collaborative, CPQCC, is to some degree similar to the Vermont-Oxford network that Dr. Horbar has been talking to you about. The CPQCC is a state collaborative. Our members include almost 140 NICUs, which is more than 90% of NICUs in the state. And what distinguishes from Vermont Oxford is that we're a real perinatal quality collaborative, meaning we have a maternal arm, which has about 250 maternity hospitals that are its members. And so our main functions, though, are relatively similar, and they generally include, for both the neonatal and the maternity side, similar to Vermont Oxford, audit and feedback. We're a quality improvement organization, so that's the bread and butter. We think without assessing data and feeding that data back and benchmarking against other hospitals, where we can't really know whether any of our interventions are truly representing an improvement. And so the data component is critical for us. And we also conduct quality improvement interventions such as collaboratives or small group interventions, either in online settings or in personal collaborative settings with about 20 to 30 NICUs and at times sort of statewide collaboratives on the maternal side. We have an education component. We have annual meetings. We have webinar series, et cetera, through which we provide outlets for education throughout the state. And then we also conduct quite a bit of research, that's epidemiological research, as well as sort of quality science improvement efforts.
Excuse me, Dr. Profit.
Yes.
I'm sorry to interrupt you. Your slides are not in full screen mode, so we can't really.
Oh, that's true.
Thank you.
How do I not know to do that? Is this better?
That's perfect. Thank you. Thank you.
10 months into Zoom, right? Okay, well, here you go. Now you saw all the great things I'm going to show you already saw. So anyhow, so with regard, so, you know, CPQCC, MQCC, the maternal side, we're really like, we'd like to think of ourselves as one perinatal collaborative. And Dr. Jeffrey Gould is the PI of both of those entities. And Elliot Main is the medical director, who many of you may know on the maternal side. So with regard to audit and feedback, so we have created a disparity dashboard, and I'll show you some of this. This dashboard is particularly focused on areas that were disparity sensitive, and we're in addition trying to develop more disparity sensitive measures. We're just beginning a 30 NICU pilot on measuring family-centered care, which in our qualitative research has really been shown to be the primary driver of disparities within NICUs. We've found few instances in our research where providers directly treat babies differently, but they do treat families differently in the NICU. And so babies may be sort of the secondary victims of not receiving enough information, just worse interpersonal relations, less education. So I will show you some of that. On our QI focus, this is really kind of technical change, and maybe we can talk about this a little later, but really the primary questions with regard to what is the most impactful as we have this moment that's focused on disparities throughout the last year. You know, is it going to be, are we going to make technical changes that improve care? Standardization of care, the things that Dr. Horbar has shown to you that have made tremendous improvements in the neonatal world as well as in the maternal world over the last decade or so, and which have narrowed the racial disparities gap. Are we going to rely on those? Are we going to rely on adaptive changes through the education-focused issue topics? Such as anti-bias training and such. So with regard to technical change, we have a health equity task force. Of course, none of these are purely one or the other. Like there's a little bit of both in all of these things. But our technical focus here is trying to address some of the structural racism whereas maybe some of the more adaptive change in our task force is working on within NICU disparities, looking at interpersonal racism, maternal education, maternal empowerment to raise the ability of families to advocate for themselves and their infants. We're also having a look at care transition through our high-risk infant follow-up programs that follow patients up to 3 years out, and we have a really probably the country's only comprehensive population-based high-risk follow-up program that's integrated into CPQCC currently through COVID. There's been huge efforts to kind of transition to telehealth efforts, which has substantially affected populations that are underserved, Black and colored populations. So getting these babies seen via telehealth rather than in office has been a large focus there. We are planning and we're trying to get funding for that, and that's one of the difficulties in this work. We're trying to find funding for a collaborative of safety net NICUs. A lot of the work presented by and done by Elizabeth Powell and others on this call has really shown the large differences that care in the hospitals that serve these populations might be problematic. And so unfortunately, even though our collaborative work is really quite cheap, safety net NICUs are less likely to participate in these collaborative. And that's typically for financial reasons when we ask them. It's sometimes also for just not having enough staff that can be dedicated to these efforts. And then we're also making sure that we implement a disparity aim into our quality improvement collaboratives. So where these collaboratives are typically focused on a specific clinical topic, we want to ensure that through the quality improvement work that we're not actually widening the gap between underserved populations and those that are not. In terms of the education, we have an annual meeting that's now for the 3rd year in a row is focusing on equity. That's going to happen in March. We've developed a disparity tip sheet for NICUs to get started. This was developed with input from former NICU families and representatives from underserved populations. CMQCC is doing a lot of work on the adaptive side, which is less than we do. So they're really trying to actually go beyond anti-bias training in collaboration with the state and the March of Dimes. They're conducting surveys of patient experience focused on respect, and they're trialing things such as active bystanders for microaggressions. Many of these things, of course, can be trialed in the NICU as well. It's just that a route that they have chosen first. There's a unit ambassadors, which is, I think, similar to our a family advisory boards that Dr. Horber has been mentioning, trying to use people that represent underserved populations to be part of these ambassadors. And there's efforts to integrate cultural humility during staff recruitment and onboarding. Let me give you just a few little examples here. So this is what our CPQCC equity dashboard looks like. Each NICU, when they open our general quality reports, will see this as their primary, as the first site, and we kind of highlight process measures. On the real report, there's also our own outcome measures for each NICU, and they can compare themselves to various comparison groups over various times. It'll show them what the population in their unit is, and it'll highlight areas that are that show a significant problem. Because the numbers can be small in individual NICUs, we do educate our NICUs that even though something may not be statistically significant, it is worthwhile to look at these data, even if it's quote unquote green, because there might be some substantial differences that just don't quite reach statistical significance due to small numbers. I think Jennifer, Dr. Janovic mentioned catchment areas or neighborhood environments. So we're working on this as well, where here you can see NICU catchment areas by socioeconomic status, and we're working to integrate information into our equity reports, and then over the longer term link those reports directly to community resources, so that NICUs really have a more updated ability to look at the population they serve, their socioeconomic environment, as well as the existing resources in the community, which will hopefully then support the follow-through efforts recommended by Dr. Horvath. Here are sort of some of the areas that we're working on this kind of our framework for disparities work. There's a huge area of social determinants of health, and then babies kind of are born and they're in the hospital. Most of our work has really focused here on the hospital. A lot of previous work is focused here, but really much of the efforts for us neonatal providers has been in the hospital. CMQCC also in the hospital, but also kind of trying to get into the prenatal care areas. Transition to home efforts happening there, and then higher risk infant follow-up, trying to kind of get the follow-through part off the ground. Here's an example on the safety net hospitals, a little bit different in California compared to New York, which is why we are interested in taking care of these or interacting more with these hospitals, is that we actually don't see this big divide between safety net hospitals in terms of outcomes compared to other NICUs in California, as Dr. Howell found in her work. When we look at statistical results, there's actually no difference in terms of survival without major morbidity, the ones that were previously mentioned. You can actually see that there's some, even though there's a little bit more of a cluster here on the lower areas here, you can see that there's some NICUs that actually have quite high survival without morbidity ratings among sort of the top quartile. So we're trying to understand like what is really driving these differences. This is an example of sort of the frameworks we make available and the tip sheet for NICUs to kind of get started. We're trying to keep it pretty simple. There's just 10 ideas, but on the tip sheet, Dr. Horvath has mentioned that he's written over 70. But we're getting started little by little. Here's sort of this technical versus adaptive disparity solution. What's going to work more? Like obviously it's going to be a combination of two, but we can't probably do everything. There's 70 things to do, and a lot of this can be overwhelming. You know, quality improvement itself is a disparity reduction effort, I would argue. Here's an example from Elliott, Maine, in the statewide collaborative on severe maternal morbidity. This collaborative had no distinct disparity component to it. But when we looked at the data after its conclusion, the initial baseline rates here shown in blue for Black moms were substantially higher than for the other groups. But after the collaborative, which is really just all technical and making sure that there's hemorrhage cards available, et cetera, afterwards, essentially the disparities nearly went away. And so I'll leave it at that. What might be better, I'm not quite sure, but we're trying to work our way through it to figure out which way to go. Thank you.
Thank you. And next we will hear from Dr. Mary Dalton, who is Chair of Obstetrics and Gynecology, and also the Willard C. Rapley Professor of Obstetrics and Gynecology at Columbia University, Irving Medical Center. And I will direct the same question to you, Dr. Dalton. If you would please describe for us current efforts in your organization or at the state level here in New York that highlight novel models of care aimed at improving the health of the mom-baby dyad, specifically for underserved communities. Thank you. And I see you are setting up your slides.
Sorry, I was just getting off mute. And first of all, thank you so much for the invitation to be part of this today. It's really a privilege, and I'm very, very grateful to be with all of you today. For my talk this afternoon, over the next few minutes, I'm going to give you an example of 3 models of care that we have at Columbia and at New York Presbyterian that we've developed over the last few years. I'll start with our most developed model, which is our fetal center that we call the Center for Prenatal Pediatrics. And we opened that in 2010, although we did it virtually since about 2005. As you all know, optimal care for a fetus that's diagnosed with a birth defect or congenital abnormality requires multidisciplinary collaboration, as no one doctor no one provider can take care of a fetus with a diagnosed fetal abnormality. To put it in perspective, birth defects account for about 2.7% of all deliveries. The incidence has remained unchanged for the last 50 years. They represent a large number of admissions to our NICU. They are very challenging for children that need to have more long-term care. And in my opinion, the family tragedy is probably immeasurable in many instances. For those of us who do ultrasound, telling a mom that there's something wrong with her baby is probably the most difficult thing we do in the ultrasound unit. So what we do in the center is bringing together expertise that gives the family a single point of contact and enhances collaboration because there's a detailed plan that's known by everybody: neonatology, pediatric cardiology, pediatric cardiac surgery, and most importantly, the family. The family understands the plan. This is very critical for family that need support to optimize the health of more support to optimize the health of their baby, and serves really as a very important point for entry into our healthcare system to build trust at a time for families that may need to use our healthcare system very frequently for the early years of their child's life. The main reason that we see patients in the Center for Prenatal Pediatrics is for our most common birth defect, which is congenital heart disease, and for complicated twins that are sent to us for evaluation for laser therapy, as we're a center for that. Now, this is a recognized model. The fetal center is a recognized model nationally, and there are about 40 fetal centers that we know of across the country. There's also a research network called NAFNet, or the North American Fetal Therapy Network, to promote cooperation between all of the centers. And this has really served the knowledge, the research very well to deal with rare diseases and abnormalities that has informed us of the best models for care. At our center, just to give you an idea, we see about 700 families a year, and that has remained fairly consistent since 2010. Just my next, I don't know, can't seem to move my slides. Okay, sorry, the next one. Now, as I became more involved in the maternal aspects of care, and we saw women who were delaying their childbearing years, and there were more comorbidities. We saw women with severe hypertension, diabetes, women who were older. We saw women who had heart disease, women who had transplants. I felt informed by the lessons of our fetal center that we needed to create something similar for mothers who had significant maternal medical and surgical conditions. I could not find a model nationally or internationally for this. So we created our own model here based on the lessons learned from the Fetal Center and opened our center in 2018 on Mother's Day. We were very fortunate to have donor support to create a space where patients can be seen by multidisciplinary specialists with the same kind of parameters as we had for our fetal center, a single point of access and enhanced collaboration and communication among our subspecialists and the family. The most common reason that patients are referred to us are for maternal heart disease and for abnormal placental invasion. Pictured here is Dr. Noelia Zork, who runs our diabetic program that is specifically focused in our neighborhood, because as you know, in Washington Heights, we see a large proportion of Latin patients, and they have a higher proportion of diabetes. For the COVID pandemic, our Mother Center has provided a significant infrastructure for providing telehealth to our patients who have been COVID positive. And additionally, it has allowed us to create an ICU on our labor and delivery unit where we were able to ventilate patients in the darkest days of the pandemic. And like was mentioned by Danielle in the beginning, this provides an infrastructure so that women who are identified to have abnormal pregnancies or abnormal maternal outcomes, they are identified to be at risk for cardiovascular disease and for neurologic complications in later life. So these women need to be followed later for lifelong care. And finally, I will talk about our maternal mental health initiative that is also fairly new and was started in the summer of 2018. Our professional organizations have recommended screening for mental health for 4 years, since 2015, and referral to mental health providers if they are identified to be at risk. I can tell you that it is very difficult to get a referral to a mental health provider here in New York because many psychiatrists do not take insurance. And this was a great sense of frustration to me personally. And I was very moved by some of my patients who would say to me, Mary, I'd prefer to come and see you because you reassure me. And my nightmare was I was not going to be able to treat mental health and that I didn't have the skill set to treat mental health. So our rationale for developing a model for embedding mental health in OBGYN reflected our opportunity to enhance the health of a woman across the life course. As our leader in mental health, Dr. Catherine Monk says, there is no health without mental health. And through grants from private foundations, we were able to recruit Catherine, Dr. Monk. She's an NIH-funded investigator to set up our program in mental health in the summer of 2018. She has established a group of psychologists, social workers, psychiatric nurse practitioners that are embedded in our department and see patients in the same space as our obstetrician gynecologists. And since the beginning of COVID, has used exclusively telehealth. They offer psychotherapy, psychopharmacology, and support groups. We have seen almost 2,000 patients since the inception of the program, which shows the dramatic need that is out there for mental health. Patients have reported that there is reduced stigma as they feel that seeing a mental health provider in the same space as their obstetrician gynecologist is seen as part of routine care. Our no-show rate is very different than seen in psychiatric clinics, and our no-show rate is of the order of 3.5%. Black and Latina women have reported that having access to mental health has significantly reduced their anxiety because they're understandably scared given the media attention on the disparate outcomes that exist and persist. It is also a major component of optimizing a bonded relationship between the mom and baby and the potential for the family of having a strong foundation. As Dr. Monk, our leader, says, the womb is a very influential first home. So although none of our 3 models were solely focused on Black and Brown pregnant people, we are located in Washington Heights. One of the reasons I feel proud to come to work every day is that we deliver approximately 3,000 Latina mothers and babies every year. Our mission is to promote a culture of equity. We recognize that there are barriers, and it's our responsibility to identify and mitigate them. I personally take this responsibility with humility and appreciation for being informed by many of these conferences that I have had the opportunity to collaborate with and be educated by over the last few years. In my opinion, ensuring equity is a constant process, and these 3 centers serve as a foundation for care for many of our highest risk patients, and they have enhanced care, access, and the patient experience, and are models of collaboration and communication. Thank you very much for your time.
And thank you, Dr. Dalton. And next, we will be joined by Colette Sturgis, who is the Program Director for the Maternal and Infant Community Collaborative at Urban Health Plan. Welcome to you, Ms. Colette Sturgis.
Thank you for having me. My organization, Urban Health Plan, is a federally qualified health center in the South Bronx. If you know anything about the South Bronx, you know that it ranks 62 out of 62 health indicators. And I think that Urban Health Plan performs wonderfully in its efforts to improve the health of the mother-baby dyad. Urban Health Plan is a safety net for the most vulnerable families in the South Bronx. It is an organization that seeks to remove barriers to healthcare. Many of its departments create a safe space for women and families who may be underinsured, uninsured, undocumented, and economically disadvantaged. And the OB department at Urban Health Plan cares for pregnant and postpartum women by providing client-centered prenatal and postpartum health care. Urban Health Plan also saw the need to engage women that are not necessarily patients and connect them to community services. The Maternal Infant Community Health Collaborative, funded by the New York State Department of Health, does just that. The MICH is an extension of the daily work of Urban Health Plan. The MICH program is designed to amplify and uplift families they serve, at the same time trying to reduce poor birth outcomes attributed to racial and economic disparities by providing home visits, education, referral, advocacy, and support. Community health workers are employed in the MICH program, and they are a valuable asset to the program, and they mirror the community they serve. Pre-pandemic, community health workers conducted extensive outreach to engage and identify pregnant, postpartum, and parenting people and enroll them into the program if they wanted to be enrolled. And the women who chose not to be enrolled were given referrals and health information. Community health workers act as a bridge to healthcare and other community services that we work closely with, such as WIC, food pantries, Healthy Start programs, and mental health support programs. And during the pandemic, the MICH had to switch gears. We were unable to conduct home visits. And we also realized that not all families had access to the latest technology. So community health workers went back to phone calls, and families really appreciated that because they felt cared about, that someone was out there reaching out to them. New York State Health Department's efforts to support mom and baby dyad include the Commissioner's Listening Session conducted by MICH programs across the state in 2018. And the purpose of these listening sessions were to obtain community feedback, provide a platform for community members, and better understand root cause of poor birth outcomes. These sessions were attended by Dr. Zucker, who's the Commissioner of Health for New York State. And what was learned from these community sessions were a lot of health equity work, racial justice, reproductive justice, et cetera, involves uplifting the voices of those most vulnerable to adverse outcomes. The persistent disparities are telling us that our current interventions, while beneficial for many individuals, clearly aren't working for everyone. And the listening sessions allowed us to speak directly to the individuals receiving our services and allow them to have an active role in shaping what those services may someday be. And one result of the listening session was an increase in funding to the MICH programs, which allowed us to hire more community health workers. And this is something that the participants of the listening sessions suggested. Lastly, as a part of ongoing efforts to improve maternal health outcomes in New York State, Governor Cuomo signed into law comprehensive legislation authorizing review of all maternal deaths in New York State. This law allowed for the creation of the Maternal Mortality Review Board, charged with reviewing all maternal deaths in New York State and developing strategies to reduce the incidence of maternal mortality and disparities in outcomes. In addition to the MMRB, this legislation also authorized the creation of a Maternal Mortality and Morbidity Advisory Council, which will work in tandem with the MMRB and address the associated social determinants and environmental issues known to impact maternal health outcomes. While the review board includes mainly clinical experts and focuses on a review of medical issues, clinical care, et cetera, the advisory council is centered on a community voice. The council includes community members, perinatal professionals, doulas, midwives, and many other types of voices. Moving forward, the council will meet twice annually to ensure a community and equity-focused lens is part of the overall maternal mortality work in the state. Thank you.
And thank you all. I don't see any comments or questions in the chat, but perhaps they are in. I believe this is a question that's appropriate, unless it was previously directed at a previous panel. And that is, was there any assessment rate impact of the regional perinatal centers along with hospital of birth for outcomes and risks? I guess that's a New York or other question, but you're muted, Colette.
I'm reading the chat, but she said it was for the previous group.
Yes,
Cheryl Hunter Grant.
Cheryl Hunter Grant.
Yeah, she said it was for the previous group.
So again, if there's any other thoughts about how we bring mom and baby together in efforts, and you've each described some rather varied and rich examples in both academic, hospital, and community settings. Going forward, what are some bold steps you'd like to recommend, or even some models that you are aware of that have been tried and maybe weren't sustained that might be worth re-examining? Anyone? We could go in the same order as before, or any one of you.
I would say that my biggest fear is not being able to support and sustain the mental health program, because it's reliant on grants and on private foundations. And until we get some sort of support for mental health, it's going to be very difficult to support that. And I hate to start efforts that I can't sustain. So I'm hopeful. I felt we had to do that because from my own experience, the number of people who need mental health support and who get it is there's a gaping hole. And it's estimated that only about 14% of people who need mental support actually get appropriate mental health support. So I feel that if we can give appropriate mental health support to our moms, that's going to have dramatic impact on their families, and will also make them so much better able to manage their pregnancies. And I think it's just part of health that I feel very passionate about, and would like to be able to scale this model that we have as much as possible, but it's very much reliant on funding.
Thank you for that. And I don't know if others have comments. I think we've reached or maybe even passed our time limit, but I did want to acknowledge one of the comments in the chat, which was referring to programs for new mothers in low-income communities having nurse visits for up to a year. And I know many of us are familiar with the nurse family partnerships. So again, another example of programs that, we want to sustain, as you said, around mental health, but also, mom baby home visits is pretty much a no-brainer as how helpful that's proven to be. But I think we are out of time. I know, Dr. Prophet, it looks like you had one more thing to say. I don't know if I can take the liberty of being the one to pull the
Dr. Prophet, you have the last word since I
yes,
do
we'll
the
give you that,
transition.
and then
Go
I'm
ahead
going to
and
turn it back to our host.
Seconds. So, you know, as much as I support the notion of following through, I think like we, to some degree, we need to go upstream. Like the fact that we even need to do this to some degree means that like social policy has really failed. In, you know, there's things like family leave, like just in general, better social policy, better social safety net to improve mothers and infants' position in the community. Is probably the most impactful intervention overall. A lot of what we're doing in medicine is secondary prevention after the horse is out of the barn. So primary investments through actually social policy are probably better directed, but we'll do the best we can.
Thank you, thank you. So it is my job to, thank the panelists. And I think we've come full circle, right? We began with a focus on birthing people, predominantly women of color, and their infants, and looking at the dyad, and then really looked at systems issues. So I wanted to thank the panelists, but then transition to our agenda. Before I do that, I want to extend an apology. Dr. Howell and I would like to extend an apology to our colleagues and participants who are affected by the lack of closed caption. That will not happen again, okay? And what we will do is also to take a look at the recording if there's any way we can insert closed caption in the existing recording. Life is full of experiences to make us improve and to be honest and straightforward with each other. So I do extend that apology to our colleagues. In follow-up also, I wanted to tell you that there is no way, and I have to thank you for sticking out for about 5 hours here, but there's no way that in 5 hours, which is probably the limit of our attention span, to include everything. I've looked at the chat and the questions and answers. Obviously, we did not, have detailed discussions on many different aspects of health disparities and health equity in that lens. Now, if I can just share my screen a second, is that possible? Yes. I wanted to bring us back to where we were, okay? So we began here. And again, I'm going to try to do this in a way that, are you seeing, hold on, I think I have to do only the presenter's view. Okay, I think I was more successful than this morning in doing this. One is we can't cover everything, but we will. This is only the beginning of our discussions. So I want you to know we began with about 458 participants, plus or minus a few, and we closed today at just shy of 300. So it's a sustained effort, but we're gonna have to go far beyond this. I put the equity lens because we were continuously reminded throughout the course of our discussions is, first of all, we haven't defined health equity on the basis of what communities, youth, as well as women and residents, those in the population, define it. So I think we have some work to do in defining that, although we did comment on listening session. What is it? Who is it for? Who defines it? Why is it important? We had a lot of comments in terms of qualitative and quantitative research that tells us that poor outcomes affect not only the individual, but all of us, okay? And so, when will we know if it makes a difference? We have to hold that light to shine on the results, the outcomes. Talk is cheap, so that research must go to the extension of policies. And I thank the panelists, the last comment, which was that we're talking about health systems. We're talking not just on personal responsibility and humility, but also our ability to change the infrastructure support that supports health equity. So the next is that we do have a lot of knowledge. And so we talked a lot about the equity framework. And I'm not going to repeat this, but you heard, I think, during our discussions, all of these components, and certainly the individual and the family, and family should be in this as well, is there. But we saw discrepancies where we said, well, maybe the care of the NICU baby is not affected, but somehow we're not communicating effectively to families. And that extends to our relationship with communities that have, and sustaining structures that have in fact supported inequities. So we have a lot of work to do. So a couple of comments before I hand this over to Dr. Howell for her true closing remarks, the things that I've heard in terms of this equity lens. Ethics and leadership matters. No quality without equity, a framework for equity, follow through and accountability. We have a short attention span in this country, right? We hone in on an issue and yet we don't follow through. So we must be accountable and have sustained effort. We must be bold, but we must be centered on hope. I'm using your own words. No health without mental health, Mary Dalton just told us. And we have to have difficult discussions about universal access to care, because these disparities that we are focusing on in Black and Brown and Indigenous populations, among others, is a reflection of inadequacy of our societal policies. So I want to thank you all, but also let you know that the New York Academy of Medicine, and I thank not only my colleagues who participated in this and Judy Salerno, who's president of NIAM, we have committed in the Women's Health Research and Wellbeing Work Group to create an action agenda. We did receive responses from you. 213 responses were from the first survey questions. No, I'm sorry, 230 started the survey, 149 responded, completed the survey. And in part 2, which was the same question, but addressing infant health status, 50 responses. That's a beginning. That's a beginning. We will share and disseminate those results with you. We will take a look at the chat and all the information and begin the hard work of not stopping till we have resolved a number of the issues that we have discussed. Dr. Howell, I hand it over to you.
I'd like to put up a couple slides, so if you could share it.
Sure, I will stop sharing.
So thank you all so much for joining us today and being part of this really powerful summit, which I'm incredibly sort of moved by, because this was something that we have been working on for years, and to bring everyone together to talk about how we can do better, how we can reduce disparities and improve the health and well-being of women of color, I think is what brought us all together today, and certainly has moved me in my research career over the last 2 decades. I want us to take a moment to think about why this summit was, I think, a great success. And part of that is that we were diverse. We were diverse not only in our backgrounds, we were diverse in our experiences, our expertise. We brought this all together as an interdisciplinary process so that we can actually make change. And if we're going to make change and do things, that's what is needed. If we're going to solve complex problems such as health inequities, that's what it's going to take. We need all voices, and we need different voices to be part of the solution. I think that was something that came through loud and clear for me today, and I think it was a conscious effort as well. But I'm just really moved by that, and I wanted to share that with you. I think Dr. Arena has already gone through some of these, but I just was sort of writing down a couple of the themes and then the action steps that I heard during the day, and you'll hear some that she's already said. And the moment, I think what we really need to focus in, and we heard this over and over and over again about the role of structural racism and how it has shaped our health and healthcare. We need to be thinking about life course. That don't, Dr. Horbar said, don't ignore, basically he's talking about social risk at some point, but don't ignore social risk. We've got to think about action steps we can take to actually mitigate it. We need to follow through. And then Dr. Bryant's quote this morning, and I have heard it from another colleague about no quality without equity, and that is really very true, and it is a cornerstone of quality. And so I think that was an important theme. When we think about action steps, we heard a number of things that folks talked about, from policies to dismantle structural racism, to integrating Black and Brown women's lived experience into quality improvement and into the solutions that we recommend. We heard about importance of social policy. We heard about the educational system and how we really need to integrate an equity lens. And we heard a lot about community and engaging in quality committees. So I think this has been a really robust discussion. I've been particularly pleased that this is our dissemination phase for our research study that we've been working on for way longer than the grant funding actually reflects. And so this is really a culmination for me, and I think some others on the team, as well as I'm sure for me today. And so it's been particularly exciting, and I'm so glad that we brought in so many different voices from around the country who could really add and bring on fresh perspectives to these questions that haunt so many of us. The last thing I just wanted to end on is that the thing we talked about bold, and we certainly saw a lot of leadership from our panelists and our speakers, but it's about bold leadership as well. I just want to leave you with, I started a new job 4 months ago at a new health system in a new city. And I just want to say that the CEO of the University of Pennsylvania Health System said, okay, Liz, we're going to put reducing maternal morbidity and mortality among Black women as one of our leadership goals for all of our leadership, the CEOs and the CMOs and all these folks across our health system, which are 6 hospitals. It takes that kind of bold leadership to make, movement in the right direction. And I'm so particularly pleased that the leadership at this institution has been taking a strong stance and saying that we have to do better. I think we all feel like that in this audience. And so bold leadership is the one last thread that I think is really important, that we all need to make sure across the country that we have leaders who really embrace on this journey with us. I'd like to conclude by just thanking all the people. There's so many people who worked on the logistics and making sure that this summit was a success. And you'll see, folks, Amy Balbers, Laura Provenos, Donna Fingerhut, Mahima Krishnamurthy, our tech team, the eval team at NIAM, and then the research team who's been working with me on all this work. We want to again extend our gratitude to the planning committee, the NIAM Women's Health Research and Wellbeing Work Group, and then a special thank you to all the speakers, the panelists, and the moderators who did such a wonderful job of weaving the conversation together. Thank you very much. We can and we will do better. Take care and stay safe.
Thank you.